involved in the summit process. I want to send a special thanks to Dr. Bruce Jarrell for joining us this morning, as well as Dr. Robert Gallo for their remarks to follow. I also want to thank Dr. Jay Perriman, Dr. Roger Ward, and Dr. Flavius Lilly. I really think we need to thank them for taking a giant leap here and leading an issue that might involve even hard conversations and difficult conversations to have with ourselves and with our partners, and doing it in such an innovative fashion and in such a complicated times. So you really have to be open and brave to ask tough questions, and I really appreciate the leadership giving us the opportunity to have these conversations at the University of Maryland, Baltimore. I also want to thank our planning committee, Dr. Titus Devala, Dr. Miriam Leifer, Dr. Manhattan Charurat, to all our wonderful speakers, panelists, students, and faculty leads that worked to get this summit to be a reality. Of course, to my summit planning team, Amy, Virginia, Bonnie, Lauren, and Monica. I just want to do a little housekeeping, and we have a lot of moving parts around the summit. We try to make only one link, only one webinar space. So sometimes you'll see people jumping in a little earlier. So please be patient if someone jumps in, and it'll take a second or two before we kind of bring them to behind stage. The webinar, the technology only is as good as our imagination, but just be a little patient with us. If someone's mic is failing, we'll intervene, try to come back to that person. We beg for that, and we really appreciate your patience. So I will provide my welcome remarks in a few minutes, but I first want to welcome the president of the University of Maryland, Baltimore, Dr. Bruce Jarrell, to the stage. Dr. Jarrell, welcome, and thanks for joining us this morning.
Thank you, Dr. Guzman, and welcome to everyone. I know many of you are on different time frames, and so it's a pleasure to welcome you here, whether it's morning, afternoon, or evening. My name is Bruce Jarrell. I'm a physician and a surgeon in the past, and now serve as president of the University of Maryland, Baltimore. It is my great privilege to welcome you here to our second Global Health Summit. Some of you may recall we had our first summit here at UMB in May of 2019. It was heavily attended. I had the great pleasure of sitting with many of you, believe it or not, face to face in a room back then. There were people from Baltimore, people from all over Africa and other parts of the world, all UMB associated programs. I made many good friends during that summit. I hope you did too, and I've kept in touch with a number of you. But I think, as you all know, today we're virtual, but I certainly hope that being virtual doesn't dispel the opportunity to have active dialogue as well as to make new friends. From the point of view of this summit, there are 265 participants from 25 countries, many time zones and geography, but I'm pleased to think of us all as one UMB family, and I welcome you. All of us have a common thread of being committed to working to advance health, well-being, and justice on a global scale. Global health and the threats that have been to it over the past year have certainly taken on new meaning to me. But at the same time, it has highlighted how we're all interconnected. One just has to watch the news every evening to know just how interconnected we are. And although this global threat has meant that we could not meet in person, I'm personally aware of the many activities that have still been taking place at our many locations, some of which are represented here. And it's not prevented us from serving UMB's core purpose, which is to improve the human condition and to serve the public good around the world as well as in Baltimore. So we have been doing that, and I want to thank you all for being here. Our first Global Health Summit focused on UMB's global health research. It demonstrated to me just how effective our teams have been throughout the world. Today is our second Global Summit, and we plan on focusing on a different topic this time, global health education. We have some experience with global health education, and I'm happy to say we've expanded it over the years. But we meet today to learn more about this topic. And I want to start by saying I come to listen. I come to listen to all voices, but especially those of our students, because I want to learn how we as a university can be more effective and more comprehensive in our approach to global health education. I have to be honest with you, when we initially started planning this summit, I thought I had a good understanding of this topic. But as I looked into it and listened to my colleagues and learned more about it, I certainly found out that I needed to broaden my view of global health education. And I have done some of that. And for example, I've certainly learned that global health and how it is taught usually reinforces Western medical ideas and practice, what I grew up in, of course, and frequently overlooks other forms of practice and knowledge used in other countries and cultures. And I might say practices at work. So I am hopeful that we can learn from these practices, apply them to our UMB programs, and make them even more impactful. So that to me is a fundamental objective of this summit. It's to hear about these practices, to hear the voices of future professionals and educators from Baltimore as well as around the world, to hear your opinions, their opinions, to hear their ideas that we can take action on and integrate into their programs. These ideas should stimulate us to re-examine some of our assumptions and practices underpinning global health education. So I hope this will lead to a new shared vision that will help guide UMB's global health work. And I look forward to that vision. One last thing, I am really very proud of the role that UMB has played in facing and fighting the pandemic. Our impact would not have been possible without good science and great teamwork and a global attitude toward the problem. Many partners worldwide, I don't need to underscore them. Most of you are representing them here on the webinar. When I think about UMB's role in fighting COVID-19, HIV, malaria, and many other infectious diseases, I can't but think of what are the centers at UMB that cause this impact? What are the programs, the institute, particularly in the School of Medicine, but linked throughout UMB? And there's a couple I just want to give a shout out to because, of course, they're spectacular programs. The first is the Institute for Human Virology. This has led the fight against HIV/AIDS for many decades and other chronic diseases. They have continued to be an international leader. The second one that comes to mind is our Center for Vaccine Development and Global Health. This program, founded over 40 years ago, has changed the very landscape of vaccinology. The work of CVD, particularly on COVID-19, has given us hope that we can survive this pandemic and also prepare for the next. Back September 11th of 2020, so 9 months ago, I was one of the first people to receive the Moderna vaccine in one of the CVD's clinical trials. At the time, I didn't know what I was getting, but that's what I got. And it was a great honor for me to be part of that trial. A third center that comes to mind is the Center for International Health, Education, and Biosecurity, CIHEB, or CIHEB, situated in the Institute for Human Virology. Although originally focused on HIV, it has become extremely involved in COVID-19 as well in many countries on the African continent. I thank them for that. And lastly, the sponsor of this, organizer of this summit, the Center for Global Engagement. This is a center that's educationally funded and based. It has sponsored hundreds of students and dozens of faculty to go and be involved in critical projects worldwide over the last half dozen years. And this center will be launching this month an international operations initiative that will bring together further infrastructure to support and facilitate many of UMB's international operations. You'll hear more about this later in the summit. The last comment to make relates to a process that UMB went through in the last several years. It was designed by the American Council of Education, ACE, and it's called the internationalization process. This was a several-year self-study process to help us understand all of the global activities at UMB. And my golly, were there many of these? And so as a result of that study, a number of strategic initiatives have been developed, which we are now in the process of implementing to make our global view even stronger. And among those initiatives, you already heard from a newly hired UMB Global Health professor, Dr. Guzman, who was leading this amazing summit. So I think you can conclude we have deep roots in global health and education. And if we work together as a team, we will continue to be even more impactful. And that excites me. So I want to celebrate our success today and the next several days, but get down to work and define the future of global health. I want to give one other shout out to the leadership of the Center for Global Engagement, Professor Virginia Rowthorn, Bonnie Bissonette, Monica, many of you who put together so much effort into making this happen. I know it's a lot of work. Thank you for your hard work and dedication. I am sure that you will have an impact on global health. So thank you for that. I also want to just thank you, although I can't see you. I know we have many old friends that I got to know in Africa. I want to welcome you here and look forward to seeing you. So with that, I would now like to welcome Dr. Robert Gallo. Dr. Gallo is the co-founder and director of the Institute for Human Virology at the University of Maryland School of Medicine. Dr. Gallo is an internationally recognized scientist and leader in virology. His vision has made the Institute become such an international force and to have an impact perhaps beyond his original vision of impacting so many people in need of care around the world. So I'm so pleased, Dr. Gallo, that you're joining us here for this summit and look forward to your comments. Dr. Gallo.
Thank you very much, President Jarrell. It's both my pleasure and my honor to be invited to speak here with you and after you. And I thank you for your kind introduction. I want to just say that the President Jarrell obviously had many things to say, could have used much more time. I am really here only as to emphasize our commitment to UMB's global health program, our involvement in it for virus infectious diseases. This is the hub on the campus at UMB, though I want to make clear there are other outstanding virologists that are not part of our Institute of Human Virology that are on the campus. And I wanted to say a bit of how this actually happened. I think it's clear from the first two speakers, President Jarrell and me. You heard his background from surgery to leadership at the UMB campus, and in addition to leadership in UMB campus, an entry into global health. It clearly, when he was born, it wasn't destined that that would be exactly the case. And even more emphatically, the same is true for me. There are many doors, I think, to come into public health and public health programs, many pathways. And my career was started at the National Cancer Institute at NIH. I was there for 30 years. And really, even though an MD, I really focused on experimental laboratory. I don't want to really say basic research. It was always kind of translational, but it was laboratory-based research, not in a clinic anymore after my first year. And I really never, ever expected to be involved in global health in any particular way. And in 1980, we had discovered what's known as the first human retrovirus. It's the only known virus that causes leukemia and is actually much more prevalent in some areas of the world far from the shores of the United States, and that includes parts of Africa. The closest where we have significant infection in the Caribbean islands, and that's where we had our first collaborations, but also in many countries, as I said, far away. No time to get into all of that. But this kind of, or actually did, bring us into epidemiology, public health by necessity. That was the beginning. Then came HIV. So we were, of course, deeply involved in HIV from the first. And that really made major collaborations. And it really was greatly stimulated. Things happen sometimes by chance, sometimes maybe that's almost a destiny. but Dr. Lashley Abimiku joined me at the National Cancer Institute as a postdoctoral fellow. She was the first one I had from Africa ever. And it was clear in a relatively short period of time that her heart was in research that would help her homeland. And so I had a collaborator at the National Cancer Institute by the name of Dr. William Blattner, and that initiated a collaboration. We left to come to UMB campus. That was in 1996, and Lashley came with us and was the first postdoctoral I ever knew that went back and forth to her home country. She didn't brain drain and stay in America, but nor did she leave. She connected us. So that began an intense collaboration with Nigeria, really focused in Nigeria, no question. And then came President W. Bush's PEPFAR program, President's Emergency Program for AIDS Relief, that Dr. Blattner, as head of epidemiology in our division, so when we formed the division, we made it into clinic, basic science, and epidemiology. Those were the heart of it, and then animal models. And that evolved in time with greater emphasis on one or another. Dr. Blattner retired, and fortunately we had in the wings Dr. Manchariat, who took that divisional position. That evolved further into his not only having an IHV position, but heading a center that President Jarrell mentioned called CHIB, as we were just now very deeply involved in African collaborations. So I know where my strengths are, and they were more in conceptual laboratory science. And that's what I kind of emphasized. But little by little, you're drawn into more and more real collaborations with people abroad, not just in Africa, but heavily in Africa, mainly because of this PEPFAR program. Now today, there are we are a total of 8 centers in Africa. And the last the two new grants in Mozambique and in Malawi are actually now headed by Dr. Abimiku. She really is a force for us in all our collaborations throughout Africa, and an advisor in many special ways. But we form links with, of course, the countries that we are involved with other senior people. And I wanted to also mention that we have a scientist who is public health grounded heavily, but also laboratory research based from Nigeria as a full professor, Dr. Clement Adibamowo, who is also from Nigeria and works in our division of epidemiology and prevention public health relation. I want to really close by saying that we are really committed to the fostering of further collaboration, true collaboration, research collaboration, education, but also lab collaboration, as well as clinical care with our African colleagues, who we are really grateful for that collaboration. And frankly, we think that as the future unfolds, this will be more and more intensive. And we are really proud and happy to have the major interest of President Jarrell and Chancellor Perman in this global health program in relationship to our institute. Thank you for these moments, and if I'm available if there are any comments or questions as we go along.
Thanks, Dr. Gallo and Dr. Jarrell. It's great to hear your words, and I'm flattered to be part of this and be sharing a screen right now with you and all of your experiences, what your work has meant to global health. So thank you for your kind words. I'm going to move the agenda along, and I'm going to give my welcome remarks right now before I welcome our keynote speaker for the day. So I appreciate that once more, Dr. Gallo and Dr. Jarrell. I'm going to share my screen, and we're going to start with a little let me see. We're going to start with a bit of trivia here to get your juices flowing. And what we're going to do is we're going to open up a poll right now. So a poll will appear on your screen if you are on your computer or on your phone. So Lauren, I kindly ask you to pull up the poll. Let me know when it's ready so people can vote. Here we go. So I'm seeing the live results right now. So the question reads, of the almost 1 billion vaccine doses administered so far, what percentage have gone to high and middle income countries, and what percentage has gone to low income countries. So is it more or less 50-50, 85-50? This is great. I see a lot of votes coming in. And although the majority of people seem to be voting for option number 3, which is 96 to more or less 4%, sadly, the people that voted 99.8 against 0.2% are the ones that are correct. So when we look at recent data from WHO and where vaccines have been distributed, around of every 1,000 vaccines, right, only around 2 go to low-income countries. That is astounding inequity, right? And so why this topic now? We can't talk about this topic in this context and not talk about COVID. Definitely over the past year, COVID has ravaged economies, health systems all over the world. It has exposed many vulnerabilities in our society, and it's just that inequity within society has fueled the spread of the virus and really leave us wondering what comes next. There's been clearly a radical uneven distribution of health, social, and economic risks that are associated with the pandemic. And because of these risks, the differences between our societies have become ever more apparent. It has really revealed how unequal our societies are. And when we look at the numbers, right, when we look at illness and death from COVID-19, it definitely has been higher among people and communities that contend with poverty, unfavorable living conditions, unfavorable working conditions, discrimination, and social exclusion. The COVID-19 pandemic has brought renewed attention to these inequities, not just in the US, but all around the globe. Here in Costa Rica, where I live, most people that are dying from COVID-19 are from low-income countries. And this really has led to many ask questions around why are there such injustices still in our global health system? And how do these unjust arrangements and structures came to be? And that's the question we're going to try to ask to move forward better. Health equity as a concept is widely touted as global health DNA, reason to be, right? Ethos. And yet our current pandemic underscores that the field really must do more and we must do much better. So as part of that conversation of doing better, here at UMB, we bring the conversation of decolonization forward. Recently, a group of students from different parts of the world asked this question: decolonizing global health, if not now, when? And this is a publication from BMJ, and I'd like to read this quote from the students. We see this pandemic as an opportunity to critically appraise what is not working and to offer an alternative vision for the future of global health. Global health needs to be integrated, decolonized approaches, advanced by individuals and institutions that address the complex interdependence between histories of imperialism with health, economic development, governance, and human rights. The global movement to decolonize global health, led by students and other professionals, is one step towards this vision. So in order to understand this in context, we have to go back in time. If we're going to talk about decolonization, we need to talk about the history of coloniality, right? The colonial project, as Europeans power knew them, it was not just only to expand their territory, but actually to settle there, conquer, dominate, right? And this mindset really took off from the big European capitals in Lisbon, Madrid, Paris, London. And the vision was to remove power, right, from the colonized and install new power structures to transfer resources, knowledges, anything, even humans, to the capitals, right? And this was done usually in the name of civility many times, or sometimes what we call progress. And it's definitely, when we see the history of coloniality, it was based on racist ideas and notion of superiority. Sadly, when we look back in our history, we see examples of coloniality in medicine helping out the European colonial project, right? There was a role that physicians and scientists kept, not just in understanding and treating new diseases like malaria that allowed the Europeans to advance into sub-Saharan Africa, right? Or sometimes in Asia, but also the creation of these scientific theories that justified and quote unquote rationalize racial differences and the superiority of white Europeans. And this was all to support these extractive mindsets of things like ivory, slaves, sugar, cotton, rubber, tea. And there was this narrow focus on helping the white European, right? Eventually, from this mindset, it changed in an arc in which from that colonial, right, we went from the colonial to the neo-colonial. And today we see still some spillovers on what that means today. We see spillovers in the form of deficit models when we work in global health, right? And by that I mean, oh, countries in the global south don't know what they're doing. They need the help of us in order to solve their problems, us being global north. And there's 4 characteristics that usually come out very clearly when we approach global health and in a non-equitable fashion. One of them is it's very top down. It's very vertical, right? There's little consultation with local communities. And when consultation is in place, it's usually very tokenistic. There's a strong emphasis that there's magic bullets out there that can solve every problem, right? And we forget about the role of the social determinants of health. There's other reasons, and people usually tout these reasons that, oh, this is something that we do for altruistic manners. But health improvement sometimes becomes just a goal for exploitation and profit. And finally, we see still some approaches that follow a neocolonial approach when we talk about health interventions that are used as soft power to gain political and economic influences over a specific geopolitical agenda, right? And I'm borrowing there from the work of Dr. Pérez Escamilla at Yale. So this topic has been touted as hot, in vogue, right? And when we look at the literature, this is a Scopus chart in which we look at the amount of literature being published under health and decolonization or neocolonization. And we can see a clear trend here, right? So people say, oh, this is hot. This will be out in a couple of years. So why even worry? I would kind of push back. This isn't a hot topic. This is a topic that needs to stay. Just like we've been grappling with racism in the US, it's a topic that needs to stay. Just like women have been grappling with gender equity and feminist approaches in all realms of life, it's an approach that needs to stay, right? So this isn't a hot topic. This isn't something that's just in vogue that we're talking about. This is something that we need to really incorporate into our conversation today. But I've also said, oh, this is a new idea. Why come up with it now? This isn't a new idea. When we look at several traditions in the global south, the idea of decolonization has been present beyond just the movement of independence. There's been a lot of light being shed in regards to how do we understand ourselves from the global south in a decolonized way. And these are just a sample of actors like Frantz Fanon, Edward Said, Paulo Freire, Ngugi wa Thiong'o, and Linda Smith, who have written from Voices from the Global South about what it means to decolonize research, politics, education. So it is not something that is new as well. It is not hot, it is not new. It is something that has just recently been incorporated in the global north ethos, but it's something that has been here for a while. So when we talk about global health and decolonizing global health, we need to think about, basically, I've been extracting what we mean by it from these four pillars. One of them, it means to rethink the theories, the process, the methods that guide global health that have gone hegemonically imposed and have gone mostly unquestioned. We've normalized our methods, our processes, our theories, and we stopped questioning them. We stopped being critical with them. The other thing is appreciating that there is distinct knowledge systems in which we can build upon, There's distinct worldviews. There is not just one worldview. The biomedical worldview and knowledge system is just one of many, and we need to be able to complement them. It's also about creating these environments where there's trust and there's the possibilities of creating equitable collaboration and partnerships. We've seen UMB is a great example of how do we do this. So we want to borrow from the UMB experience to share with the rest of the world. And we also see the need to balance power dynamics to reflect shared responsibility. And I've talked about this before, and some people have said, Carlos, this is all very nice. It sounds very soft though. And I also must be highlighted though, that decolonization sometimes also entails acts of resistance and opposition, as we saw from the Rhodes Must Fall movement in South Africa a couple of years ago. I hope our following keynote addresses this aspect. We want to be really intentional with our Global Health Summit. And one of the things when you visited the website, you'll see is our statement of intent. What do we want from this summit? We really want this to embody an attempt to establish a productive, action-oriented dialogue towards a new global health field. And we're bringing together practitioners, researchers, educators, students, trainees, stakeholders from different parts of the UMB system and from different parts of other educational systems in order to advance how we do diversity, equity, and inclusion, right? So it's a very intentional attempt. So it was important for me to state this at the opening. As part of that intentionality, we had to do some work previous to the summit. The summit is just the outer shell of what this summit is. But we've been working with summit scholars, which are trainees from all over the world and our different partners, more than 90 students and trainees from 9 different countries, from the 7 schools, pharmacy, social work, nursing, dentistry, medicine, graduate school, and pharmacy have been participating actively in this process. We've engaged 35 faculty members from our faculties and from our partners. And we've engaged 8 partner sites, including students and faculty from those partner sites. So when we think of the word summit, we're actually thinking of a peak, right? Oh, let's do the summit is what Clymer said, right? So we similarly have chartered a process in which summit scholars are working up to this. And as part of that, right, is that we place a lot of emphasis in the future of global health, which are the student voices. These are the logos of our great summit partners. Participation from these groups have actively engaged in the discussion and have advanced that discussion, and that's what you're going to hear throughout this summit. As of participants, right now attendees, we had this morning around 460 people confirmed. We almost have 200 people in this room right now, which is extremely exciting. And as you can see, we have representation from many parts of the world, which makes me also very proud to be part of this university. As a broad overview of what we're going to be doing right now, right, we have the 2-day summit and we have a 3rd-day internal conversation to advance the conversation or the topic in Decolonizing Global Health at UMB. But for the purpose of the people that are attending right now, you'll see that the agenda places at the middle of kind of as its main course these hearing from the future interprofessional student panels, in which we're going to be talking to trainees from different careers, and we're going to be trying to extract from them their ideas about what it means, what this topic means for the future of their profession. And then we're going to have expert reactor panels that are going to be talking about what the students were saying, but also bringing their insights and their work into it. I really want to invite you as well to our both keynote speakers, 2 keynote addresses. Following this, Dr. Ijeoma Nnodim Opara, and tomorrow a conversation between Dr. Agnes Binagwahu and Dr. Samba Sow, both former ministries of health in Rwanda and Mali, respectively. And then today in the afternoon during lunch, we'll have an amazing conversation around the intersections between diversity, inclusion, and diversity, equity, and inclusion, and decolonization. And we have 2 amazing members of the University of Maryland faculty, Dr. Courtney Jones-Carney and Dr. Thurka Sanguramurthy, that will be speaking to these intersections. So again, I want to welcome you. It's incredibly exciting to be here. And now I'm going to move it on to our keynote address. So I want to welcome to the stage Dr. Ijeoma Nnodim Opara, who is a close friend of mine. We've been working together for many years now. I've had the pleasure of hosting her in Costa Rica as well, and we've been working on faculty workshops, actually, training faculty to be better global health educators. She is currently a double board certified assistant professor of internal medicine and pediatrics at Wayne State University School of Medicine, where she's also the associate director of the internal medicine pediatrics residency program and an attending physician at Wayne State University Physician Group. Ijeoma's bio is quite extensive. I invite everyone to go to the website and read all her bio. I'm going to go through some short snippets of it, but I do invite everyone to go to our website that will be posted right now on the chat and visit and get to know more about Dr. Nnodim Opara's work. She is an incredible, innovative educator. She's created amazing courses, tracks, even fellowships that combine critical reflection, community engagement, scholarship and research, and even advocacy to advance the different structural determinants of health and health disparities. She co-founded in Wayne State the Global Health Alliance, which is a multidisciplinary organization that creates a unified and regional a group of global health practitioners that advance global and urban health. She also created and co-founded and directs the Global Urban Health and Equity Curriculum, which is called GLUE, which is, again, an interprofessional comprehensive certificate, competence-based global health curriculum. Her academic interests are in health equity, justice, social and structural determinants of health, and interprofessional education. She has a long history of leadership and service to the African immigrants and African American communities, and co-founded Africans in Medicine, whose vision is to unite African medical professions to further the health interests of Africans living in the continent and in the diaspora. She's a committed activist. She serves in the Wayne County Medical Society Public Health Committee, as well as she serves with me at the Consortium of Universities Global Health, a competency subcommittee and network of academic advisors where she improves policy development and supports global health and international development. Ijeoma, welcome to the stage. Welcome to the Global Health Summit. It's a pleasure to have you here. Really excited to hear your keynote address.
Good morning. Good morning. Good morning. Can you hear me okay,
Ijeoma,
Carlos?
we're having issues with your audio.
Okay. You cannot hear me at all?
No. Oh,
Michael says he can hear fine.
I hear from the screen someone saying,
I can hear you fine.
okay, so you can go.
Apparently
it's mine. Go ahead. You're good.
You sure?
You're good to go.
Okay. All right. All right. All right. So allow me to just take a moment. Old pirate, yes, they rabbi. Sold I to the merchant ships. Minutes after they took I from the bottomless pit. But my hand was made strong by the hand of the Almighty. We forward in this generation triumphantly. Won't you help to sing these songs of freedom? 'Cause all I ever had, redemption song, redemption song. The courage to be free, cultivating a decolonizing imagination. Thank you, Dr. Ferron, for your outstanding comments. UMB leadership for inviting me on this beautiful summer evening to have this conversation. And thank you to everyone on this call to share this moment. I bring you Motown greetings from one of the greatest cities in North America, Detroit, Michigan. And I'm also representing my country of origin, one of the richest nations in the world, Nigeria. which is located in the richest continent on Earth, Africa. There's a popular quote attributed to James Baldwin that states, "Not everything that is faced can be changed, but nothing can be changed until it has been faced." But there is more to that quote, which is not often mentioned, which states, "History is not the past, it is the present. We carry our history with us. We are our history. If we pretend otherwise, we literally are criminals." In global health education, as it currently exists, do we pretend that history is in the past? Do we pretend that we do not carry our history with us? Do we pretend that we are not our history? Are we criminals? Ndubweje, onye amaghị ebe ọ si kwalie, ka o si bịa ruo ebe ọ nọ, agaghị ama ka o si eju obo na-eje ije ọma. Life is a journey. She or he who does not know whence she or he comes from, how she or he arrived at her or his present location, will not know how to reach his or her destination. Travel well. In preparing for this talk, I found myself taking a mental stroll down memory lane to my own childhood in Benin City, Edo State, Nigeria. As I'm sure majority of you know, Nigeria, one of the products of that fateful Berlin Conference of 1884, where Europe surgically arrested the development of an entire continent and violently rearranged the trajectory of humanity, won her independence from England in 1960. She'll be 61 years old on October 1st of this year. I was born at University of Benin Teaching Hospital, Benin City, Edo State in none of your business, okay. To a physician, scientist, father, and child development specialist and educator mother, both Igbo, both survivors of the Biafran Civil War, which occurred between 1967 and 1970, a complex, bloody war influenced in no small part by British expatriates and United States policy and financial interests. Hating that feeling of powerlessness, my father, looking older than his age, signed up to fight at 15 years old. It is a miracle he survived to have my siblings and I. As the first daughter in an Igbo household, I have the title of Ada, Adawiri. That is my paternal hometown in Imo State. Adas are held in high esteem and naturalized as leaders in the family structure, as well as the community as a whole. Yet I did not speak Igbo, one of the most beautiful, expressive, expansive, complex, and delicious languages in the world, because I wasn't taught. My parents would speak glorious Igbo to each other, waxing poetic, prolific, and patriotic, but then turn around and speak English to us. So I got to understand Igbo by listening to them speak to each other and their friends, but I couldn't speak the language. Now, don't get me wrong, I learned all the cuss words and insults, okay? Because that was the only time my mother unleashed the full gravitas of her Igbo vocabulary on us, all right? But other than that, I was just limited to the dry, cold, restrictive, inflexible English language to communicate the fullness of my reality. This preference was reinforced in school, where indigenous languages referred to as vernacular were prohibited. And I learned that there were only 3 main ethnic groups in the most populous country in Africa and the 7th most populous country in the world. I didn't find out that we have more than 250 ethnicities in that country, all right? And that my continent is home to the greatest amount of human and biodiversity in the entire world, till I was a super full-grown adult with children of my own and situated outside the continent in the United States of America. In school back home, I was taught that there were 3 races of people: Caucasoid, Mongoloid, and Negroid, in that order. Always in that order, always. internalizing the natural hierarchy of humans, right? Our books, nursery rhymes, stories, references were white, European, and over time, progressively American, but white American, always, always. Movies, advertisements, and media embedded into our consciousness the ubiquity of whiteness and all that, that the people of that particular phenotype who were located in the cold places have contributed to the world and humanity. I knew nothing about what people that looked like me had given to the world, had done for the world, had created, innovated, achieved before the white man came to our shores. I knew nothing of pre-colonial Africa, that she was the birthplace, she is the birthplace of humanity, that she's the pioneer of arithmetic, mining, and had the oldest agricultural technologies, that she was home to complex social organizations and her countless natural resources essentially keep the world going, and that she developed Europe and that she developed America. Through the extractive and exploitative, continuous, ongoing process of imperialism, colonialism, and neo-colonialism. I wasn't taught about the rampant violence and destruction that was the coming of the European, that white supremacy was, what white supremacy was and what global anti-Black racism was, and that they were codified in structures and systems throughout the world, informing all aspects of our geopolitical realities, be it economics, politics, culture, psychology, spirituality, education, language, the works. Like many of the educated middle class bourgeoisie, I had internalized the colonialism that besieged my country. And so it wasn't until my first encounter with truth, with history, that my journey into decolonization and towards liberation began. The truth was in a book written from the perspective of an exploited, titled The Interesting Narrative of the Life of Olaudah Equiano, an autobiography written by a formerly enslaved Igbo man who purchased his freedom in 1766 and helped to pass the British Slave Trade Act of 1807 that abolished slavery in Britain. And that book led to me reading Ngugi wa Thiong'o's Decolonizing the Mind, Frantz Fanon's The Wretched of the Earth, Black Skin, White Masks, and Towards the African Revolution, Chimamanda Ngozi Adichie's Americana, Isabel Wilkerson's Caste, Ta-Nehisi Coates' Between the World and Me, Wole Soyinka, Buchi Emecheta, Toni Morrison, Langston Hughes, Maya Angelou, Amiri Baraka, Martin Carter, Paulo Freire, Aimé Césaire, and the list goes on and on and on and on and on and on. Work that grabbed hold of my imagination, scrubbed it clean, and gently and kindly began the reconditioning. It is why today I'm Afro deep in activism and demanding for the elimination of structures of oppression, while building liberated systems where people of African descent can truly be free in their authentic selves, not performing. Where we can be safe, be valued, thrive, and prosper. It is why I founded Health Equity and Justice in Medicine and co-founded the Global and Urban Health Equity Program to begin to identify, disrupt, and dismantle systems of colonialism, white supremacy fallacies, and anti-Black racisms codified in medicine, medical education, community engagement, and policies. It is why I actively interrupt narratives that are deficit-based and strategies that are rooted in deficit narratives. Why those systems are interrupted to or designed, calling out the design of those systems to curate scarcity mindsets and systematically exploit, devalue, and exclude voices like mine, bodies like mine, spirits like mine. Because to do otherwise, to be otherwise, for me is unacceptable. To do otherwise, to be otherwise, for me is to be in bondage. So when we pretend that we do not carry our history with us, when we pretend that we are not our history, are we criminals? Emancipate yourself from mental slavery. None but ourselves can free our minds. Have no fear for atomic energy, 'cause none of them can stop at the time. How long shall they kill our prophets while we stand aside and look? Oh, they say it's not a part of it. We got to fulfill the book. The courage to be free. Cultivating a decolonizing imagination. A decolonizing imagination. Decolonization is not an end. It is a means to an end. And that end is true liberation, where we can experience true self-determination, self-esteem, self-definition, self-expression in our own languages, where we are free without interference to define what development means for us, what prosperity means for us, what health means for us, where we get to dictate our own terms for trade, exchange, and engagement, terms that benefit our most vulnerable, terms that center our values, where we get to design our own structures, our own infrastructures. And so I invite you to reflect and begin the process of imagination as to what does home mean for you? What does it look like? What does it feel like? What does it taste like? What does it smell like? What does it sound like? Decolonization is the 2021 Chevy Volt cruising down the street heading home. And to go on this journey requires courage. The courage to imagine better, to imagine different. It's the courage to dream. It's the power of a dream. Because whatever is in reality is created twice, once in our imagination, and secondly, in reality. There is power in imagination. It is literally where liberation begins. Because that is where oppression situates itself in order to draw power. The mutually reinforcing systems of oppression, whether it be colonialism, patriarchy, capitalism, ableism, white supremacy, anti-Blackness, xenophobia, homo and transphobia, all this begin and end in the imagination. The imagination sustains, supports, empowers. Imagination powers our actions, strategies, and innovations. Our potential and what is possible is only limited by our capacity to imagine and imagine different, which is then followed by our willingness to do different. A system functions as designed. We will keep getting the same results if we keep the same systems. It will need to be dismantled. To dismantle, we need to decolonize our minds. It starts in the imagination, which powers our willingness to then act, our willingness to be different. It takes courage to undo, unlearn, unbe, to deconstruct centuries of conditioning that has laid fortified internal structures of oppression, internalized structures of oppression, which we reproduce externally in our systems of education, housing, healthcare, public health, economies, justice system, etc., which in turn reinforce the internal oppressive structures, again, like a vicious cycle. And so we require courage to interrupt this cycle, a daring spirit of boldness that goes beyond challenging and dismantling, even abolishing the status quo, but builds the new tomorrow. It's not just what we're decolonizing or what we're anti-ing, but what are we building? We cannot talk about courage without talking about fear. Fear. And so I invite you this morning to ask yourself, what are you afraid of? Honestly, truly. Why are you afraid of it? Honestly, truly. Understanding that fear is a tool of oppression to maintain the status quo. I invite you to think about who told you to be afraid of it. Honestly, truly. And how is your fear cultivating, nurturing, and feeding internal and external systems of oppression through silence and inaction, through the belief that it's not your problem when it totally and completely is? How is your fear cultivating and nurturing internal and external systems of oppression through confusion and chaos, busy work, and manufactured scarcity? How is your fear externalizing internalized systems of oppression? White supremacy and mutually reinforcing intersectional systems of oppression thrives in anxiety, manufactured scarcity, and the normalization of fallacies and limiting beliefs. In many spaces, the word fear, F-E-A-R, is represented as an acronym, false evidence appearing real. Today, I invite you to choose instead a different acronym, face everything and rise. Courage is not the absence of fear. It is the willingness to persist in spite of it. It is the willingness to imagine in spite of it. It is the willingness to act in spite of it. And it is required to do the daily work of decolonizing and liberation building. And it is daily work within global health education, starting with asking questions and exploring where within your various institutional structures, practices, and norms do patterns of extraction and exploitation show up? Where is the ownership of these programs and these processes? And what does the financial structure look like? So for instance, in your pedagogies, are you teaching true history? And from whose perspective? Are you starting and locating the beginning of history with the introduction of whiteness? Are you going way to the pre-colonial era to discuss the ways in which the continent has stood the test of time? Are you framing your curriculum within a socio-political context? What are your frames of reference? Are they located in Europe and America or elsewhere? What do you consider knowledge or evidence? Do you engage in the hierarchy of quantitative over the qualitative? Are you teaching and perpetuating biological determinism and racial essentialism, which is essentially scientific racism? Are you talking about power? Are you naming systems of oppression? Are you bold to call out racism, white supremacy? Are you bold to sit inside discomfort and allow it to make you grow? In your processes, are you asking these sort of questions when it comes to the admissions of your students, the hiring and firing of faculty and staff and leadership? What does your leadership look like? What authority or power do they have? In your partnership, who is in the lead? Who owns the data and the outputs? Who determines the agenda? What do your paradigms and your praxis look like? What do your pay or compensation structure look like? What do your policies look like? What values do they reflect? What does your budget reflect in terms of your values? Throughout your institutional structures and in your day-to-day, what assumptions are you making? What language are you using? What is your frame of reference? Are you constantly grounding yourself within deficit-based versus asset-based approaches? Are you highlighting and centering stories of resistance, joy, creativity, and innovation? Or is it always about hunger and poverty and badness? What perspectives are being centered in your work and throughout your processes? This summit on decolonizing global health education is not just an opportunity to look without. It is an opportunity to look within, to find the courage to look within as an individual and as an organization. One cannot decolonize or liberate anything when one is still themselves colonized and bound. You must find the courage to ask questions of yourself. Am I willing to lean out? Am I willing to give power? Am I willing to sacrifice? Am I willing to lose, to be inconvenienced? How am I participating in, benefiting from, perpetuating or reinforcing systems of oppression? And let me tell you, it's painful. It is hard, you will cry and you will ache. But if you think freedom is free And liberation is cute. Well, I'm here to tell you, honey, it ain't. Colonialism is inherently violent and costly. So what do you think that means for the process of decolonization? The revolution is courageous. The revolution is liberating, and liberation. The revolution is you and me emancipating ourselves from mental slavery. Look, the revolution is each of you taking your time to listen to a fine Black woman on a Tuesday morning, eager to do your part, whether you are an institutional leader, educator, student, layperson, or just another human brother or sister listening in. And so I thank you for this moment. I thank you for your attention. My wish for all of us is that today will be a milestone for the University of Maryland, Baltimore, for each and every one on this call, and for the people not on this call who are waiting for us to show up courageously and apply a liberatory imagination to finally bring about the change our ancestors called for. Thank you. Dr. Farron, I pass on to you.
Dr. Nnodim Opara, that was, I'm speechless. I have goosebumps all over my skin. That was incredibly powerful, and just reading the chat, it's going off the charts. The chat is going crazy. People really want to hear more of your work, get to know you better. For the people that are listening, this was recorded and it will be uploaded so you can share it widely. I loved every word you said. It was so powerful. Thank you also for bringing a little bit of Bob Marley into your work. The great song, Redemption Song, 1979 classic. I grew up listening to Bob Marley and I was quite a fan. I think listening now to his lyrics in your words really bring another meaning to this. So I really appreciate for adding that extra layer to my youth. Dr. Opara, we'll be able to speak more offline, and we really thank you for this amazing keynote. It's really set the bar really high to what we now have to do as an event, as a university, right? It's really charted and mapped our way forward and the ideas that need to guide this. We must fight fear. We must step up with courage. We must have hard conversations, look inwards to be better. Thank you, Dr. Opara. I really appreciate your time.
Thank you, sir. Thank you, my brother. Thank you, everyone. I know there was a conversation around question and answer, but I'm also looking at the time. And so out of respect of the schedule, I will stay on the chat. So folks want to ask, and I will make myself available for anyone to follow up. I will put my contact information in the chat as well, but please feel free to use the chat to ask questions and follow up with me offline as well. Thank you so much.
Greatly inspirational. Thank you, Dr. Nnodim Opara. Oof, so after that, I think we all need a little stretch. I encourage you all to stand up a little bit, stretch your limbs, maybe change your desk to stand-up mode. And as we bring in the different panelists of our next activity, we'll have a health break right after this panel. And this is part of what we wanted to do, is bring student and trainee voices into the Global Health Summit, and we wanted to put them front and center. So right now I'm going to welcome, as they're starting to jump in, and we're pulling them kind of with a little crane into the main stage. So I asked the panelists if you could please start turning on your cameras. And I know there's some missing because this panel is around 7 or 8 people. So Francis, Janet, Dr. Seville, Ashraf, Felicity, Marcella, Jasmine, Lindsay, would you please turn on your camera and join us? Oh, Lauren, remember you have to make them co-hosts in order for them to turn their cameras on.
Got it, Carlos.
So as I was mentioning earlier, we set up this conversation and we prepared with the trainees and with the students to a Global Health Summit scholar process, in which for the last 6 weeks, 4 weeks, the students and the panelists here have been preparing for this in many forms. They've been taking workshops, conversations, readings, lectures that intersect in the different components of how the decolonial mindset intersects with their future profession. So we have today representation from different learning groups within this pre-summit process that we endeavored, in which I'm going to introduce the working group, and I'm going to call out the names of the people that are in the chat. I mean, in the panel. So when I call out your name, panelists, please just open up your mic, say hi, and then I'll get to the questions. Okay, so I'm going to start with welcoming from the CHEB, Zambia School of Medicine program, Dr. Seville. Hi, welcome.
Welcome. Good morning and good afternoon.
Thank you. Welcome. I'm going to see if I can find you all. Dr. Mupeta, hi, welcome.
Thank you very much, Dr. Guzman, and I'm glad to be here. I'm still waiting to have my camera turned on. Thanks.
Okay, no worries. We'll get to you. Dr. Toake. Can't see you. Oh.
Yes, hi, I'm here. Thanks, I'm glad to be a part of the program. Thanks for having me.
Thank you. From our dental program, we have two students. I don't see Sadataka still, but Ashraf, welcome.
Hello, thank you for having me. It's such a pleasure to be here. Thank you.
Thank you. And we also have Jasmine. Jasmine, hi.
Hi, everyone. Thanks so much for having me.
Great. From our nursing program and our nursing partnerships, we have Marcella. Marcella Leith, hi.
Hi, thanks for being here. Thank you for having me.
Thanks. And we have also Felicity Omotosho from the University of the Gambia. Hi, Felicity.
Hi, it's good to be here. It's a great opportunity. I'm grateful.
It's a pleasure to have you here. From our PT program, we have Lindsay Mathis. Lindsay, hi.
I am very elated to be here. Thank you so much for having me today.
Thank you. From our School of Pharmacy, we have Janet. Janet, hi.
Hi, everyone. So happy to be here. Thank you for having me today.
Of course. And Sadataka, you just joined in time. Hi, welcome.
Hi.
Thank you for joining us. So great. We have, I think, everyone on screen. And what we'll do is for the next 50 minutes or so, we're going to engage in a conversation where I'll be bouncing off questions from the different panelists. Now, as you might recall, they've been preparing some of these questions we've discussed together, and panelists have been able to think through these questions as part of their preparation for this. So I'm going to start with our colleagues at Zambia with the CHEB program. And I want to recall that during our workshop, as preparation for this panel, you all shared a vision of what you considered what a decolonized global health field would look like, right? What does decolonization mean for the field of global health? So let me ask you, if you're willing to kick us off by sharing your thoughts in this regard. What does decolonized global health field look? And I open up the mic of any of you three that want to take that question.
Okay, so I'll go ahead. I want to first say that this is a very important conversation to have, as we are pretty aware that global health decolonization and colonization actually is pretty extensive. The global health agenda of various major global health issues have been talked about for a while now. So I think that with global health decolonization, having the conversation around what is important in terms of people sharing ideas, discussing how to understand the cultural norms of the various countries outside of the Northern Hemisphere are important. And so it's the exchange of ideas, it's the understanding of the various countries that are visited to foster education, to foster allowing the lead of those who are there to take part in various areas of research and education, whether it's education in the area of business or medicine. We're all here in medicine. These are important things to consider for decolonization, because decolonization it's taken place over centuries. And so it's not an easy thing to just adjust and get rid of. So the fact that these conversations are ongoing, we have to really target the areas that are important to foster the countries that we're partnering with to, evolve and be better and allow them to take the lead. But in order to do that, I think that we have to take a step back and understand the cultures, the languages, the customs. These are all very important things that I think were mentioned in our conversation that we had with you last week.
Thank you. Dr. Mupeta or Dr. Seville, do you want to add anything?
Yes, I can go ahead. Dr. Seville here. And again, thanks for having us and inviting us to share our thoughts on decolonizing global health. I'll start by saying that on our part, who are resident in the Southern Hemisphere, decolonization would mean that we probably reach a point where some of the homegrown ideas from the low and middle income countries or underdeveloped places are brought to scale or brought to visibility. We do have some ideas, but the transfer of these ideas from this north to south is what's been happening, but probably we need to move ahead and see how we can transfer some of the ideas from the south to the north, especially in the areas of domesticating technology. I know there's a lot of technology in the Northern Hemisphere. The question when we are talking about decolonization is, can we bring some of this technology to be resident in the Southern Hemisphere? I submit. Those are my thoughts. I don't know what my colleague, Dr. Mpeta, thinks.
Yeah, thank you very much. First of all, I would like to point out one striking feature. If we look at this panel, and I think there are only 3 male, this shows a lot where, 10, 20 years ago, this panel would have just been full of men. And that's how it should be the same when we talk about, decolonization of global health, giving equal opportunities for people in, less developed countries. And I would, riding on the previous speakers in the opening sessions, I would want to point out that the majority of people resident in resource-limited countries do not necessarily want to, leave their countries. The majority, succumb to brain drain because of lack of opportunities, to advance their career or to practice their trade. So that being the case, one of the things that, quickly comes to my mind is, refining of curricula. Curriculum has definitely been so westernized, and sometimes it leaves so much in terms of what exactly happens here. And you find that you train somebody in their environment, but they are again ill-equipped to take care of their own, environment, because the curriculum has somehow been skewed to the West. There's also, it's also important to understand, the different dynamics when it comes to the practice of medicine in the West and also, in Africa. And this brings about to the exchange program that we have had even with University of Maryland, which is wonderful. By the way, where we are having, students from University of Maryland coming to Zambia and vice versa. Now, this should be coupled with some practicality. And what I mean by this, if you are reading in the same program and you have got this exchange program between students, why don't we develop a dual system of courses where a certain part of, course is done in the US and the certain part of the course is done in Africa. And there's easy, that is an interchange of students where somebody knows if I'm in my second year, this type of, when I'm talking about this type of, infectious disease or something, I'll learn them from Africa, in Africa, because they are apparent more in Africa. And then if I'm going to talk about, learn about, transplant medicine and infectious diseases, then I know that that part of the course I'm going to do it in the United States because there are better transplant centers there compared to Africa. Then the other things is we look at access. We mix a lot with students coming from, University of Maryland. They have got access to their online library and immense resources, whereas us on the other side, we don't have the same opportunities. So if we are allowed to mix on a global health exchange program, why don't we also have temporary registrations in the US, university, so that we could access the resources that our friends have? And this will also, reinforce the partnership when it comes to research. We've seen a lot of our students counterparts coming here and in no time being able to do a research while you've been here where the data is and you still fail to conduct a research. So there's that need to collaborate and strengthen, the twinning of, prospective research and researchers so that we can enhance, global health, not just skewed in one direction, but it should be a bi-directional way so that we can improve the health and ensure that there's fast, transfer of technology and advancement in the area of medicine. Thank you.
Thanks, Dr. Mupeta, Dr. Tokwi, and Dr. Seville for that. And of course, you're mentioning the CHEP program, which is an amazing program. I've heard a lot about it, which is, I do have to take my hat off to what Dr. Lottie Hachambwa and Dr. Cassidy Klassen have been doing with their program. And these are kind of just an array of opportunities or a sample of opportunities that live up to that bilaterality that you're speaking of, that sharing of not just knowledge, but also cultural traits as part of the education process and allowing the different moments in different educational opportunities for the lead to be different, right? Who is setting up and who is having the ownership of the different educational experiences at different times can swap. So it does take time, as you were saying, and it takes also a lot of trust. So these are all things that I've been picking up as you were speaking. Now, let me move the panel to our nursing group, which I know Marcella and Felicity, I know you've been thinking about this topic even before the summit started, right? Even before the summit was announced, you were thinking about how do we create more equitable opportunities. But I also know that you've been also, because of your training, you've been really keenly aware, bringing back to where I started, the COVID-19 pandemic, that there is a lot of structural inequities still that are part of these colonial legacies, right? And that we have seen emphasized by the COVID-19 pandemic. So why don't we start us off, and can you provide us some insights in this regard? So please.
Greetings to all, and I'm glad to be here. Okay, we're talking about the structural inequities. I would, in my own opinion, these are factors that are in place that tend to put a few people or a few groups or a few institutions or some organizations at a more advantaged positions than some others. And more often than not, those are the disadvantaged positions are usually the marginalized peoples or the minority groups. So this inadvertently leads to we having colonial legacies. As we all know, these colonial legacies, this is simply a process of power exertion by a stronger country on a weaker country. And in our case, it's no different because of our profession. We see the legacies all around us. And well, it is very important to know that these impacts have not only been negative, we've also had positive impacts when it comes to colonial legacies. So some insights I would like to share. I know my fellow colleague to Marcella, we also have some insights to share, but on my part in the Gambia, I currently reside in the Gambia. And during the COVID-19 pandemic as at last year, there were a lot of precautionary measures that were put in place that were announced by international health organizations on how to minimize transmission of COVID-19. But as we could see, many other countries, especially in the high-income countries, they announced lockdowns, they catered for their citizens, even without citizens having to work for a specified period of time. They catered for them, they brought food to them, and made sure that they were comfortable as much as possible. But that didn't apply to us here in the Gambia. Because in the Gambia, though the lockdown was initially announced, people cooperated with the government because, well, everyone was afraid, everyone was scared. So, well, let me protect myself. Government says stay indoors, and I stay indoors. So people just managed with a few, I would say, food or supplies they had. But got to a point, people revolted and said, hey, government, please let us out. This may have happened, this may have, been, well executed in some other places, but it doesn't apply to us here. You people ought to know that you should find some other strategy to put in place. Because for instance, in the Gambia, women have to go shopping every morning to the market, every morning to fend for their families, to make some food. So now you're shutting people in because, hey, lockdown measure is one of the precautionary measures and what have you. You're shutting us in. Well, it doesn't apply to us. It can't work really well for us here. So that's one of the sociocultural factors that come in place. And when you also talk about some cultural factors in the Gambia here, people are used to shaking themselves, as in with the hand, in form of greeting. Now you're telling people no shaking, stay a few feet. That affected us a little because we can hardly put that into practice here. So it brought about a very great resistance in adhering to these precautionary measures. So these are some of the social inequalities. When it comes to the healthcare system, also, COVID-19 pandemic had its own blow on the healthcare system in the Gambia, in the sense that there was chronic understaffing, usually, anyway. Let me start by saying that long before the pandemic, public healthcare facilities in the Gambia grapple with understaffing, especially nursing staff. So we grapple a lot with it. So now the onset of the pandemic, it really showed how can I put it now? It showed our weak areas. Yes, our weak areas became more evident. Now, on the staffing, especially in rural Gambia, if in the urban area we grapple with understaffing, how much more rural Gambia is much more understaffed. So the much impact was felt even in the rural Gambia. And for instance, now in the Gambia, there's only one teaching hospital, and is the only major referral hospital. So at the time of the COVID-19 pandemic, if there were COVID-19 patients, they have to move all the way. For example, maybe in the rural places, they have to move all the way down to the urban area where the teaching hospital is located. They have to move all the way down. So that distance, so all these are all legacies that have come to play, and they have really created disparities. And we realize that, to put all these ideas, all these foreign ideas into perspective in our own setting here is really difficult. It's really, really difficult. So these are some of the structural inequities. And even when it comes to maternal health care in the Gambia, before the COVID-19 pandemic, Gambia is doing quite well when it comes to maternal health care. But at the start of the pandemic, especially when it was still the waves were still really high, well, there was difficult access when it comes to maternal health care. In what sense? Healthcare workers were more interested in protecting themselves And I also like to mention that we grapple also with inadequate resources when it comes to PPEs, when it comes to ventilators, when it comes to, public, facilities and what have you. So healthcare workers were more concerned about protecting themselves, and it was announced that okay, N95 is the best mask to use to prevent yourself. But hey, long before the pandemic, we didn't have N95. We didn't. We hardly do we have it in our public health care facility. Now we hear all of a sudden N95 is the best. But thanks to God, we are grateful that this whole pandemic brought some positives. In what sense? At least at the point in time, it was announced that okay, people can now use local fabric to sew masks. So that gave room for indigenous innovation. So I also like to, comment on that. So it gave room for indigenous innovation and on our home using our local fabric, because how can the government actually get N95 masks for a little over 2 million people in a country? That's obviously difficult. So we are grateful that at least the whole pandemic issue brought about that innovation. And it also made us to realize some weak areas. So in case something like this happens, and I also like to say something like, at 2014, when the Ebola virus hit Africa, that is Sierra Leone and all that, I don't know, most probably we didn't learn our lessons, when it comes to our settings here, because now we are seeing a repeat of such, and yet it still shows low preparedness. An article that was written, that was published, I would say recently, by Jatta et al. A research was carried out in the Gambia among healthcare workers to look at their level of knowledge and preparedness. Of course, there was a high level of knowledge among healthcare workers as regards COVID-19. When it comes to the preparedness, well, there was a very low preparedness. So that article confirmed that information. So at this point, I would like to give it to Marcella. I don't know if Marcella has one or two things before I also chip in a few ideas.
Thanks for that, Felicity. And Marcella, if I may, I'm going to move it to a next question, and I know you have your thoughts here. And as we prepared for this workshop, you did signal, and the group preparing for this panel did signal that despite their ongoing efforts to diversify the nursing field, we still are seeing lack of diversity within, especially in leadership roles. Now, we can still see some exclusionary practices, and some of this takes form, the types of knowledge that are incorporated into the nursing fields. Can you share a little bit of your reflection about this on the education process, the lack of diversity in leadership? How does the nursing field then overcome these current gaps?
That's a big question, but thank you for it. I think in harking back to everything everyone else has said, the most important thing is being aware that we have this lack of diversity, that we really need to be aware. We need to look at our own systems. We need to look at who we're working with and understand that we're taking care of very diverse populations. And so as a healthcare team, we need to also represent those different populations that we care for. I think a lot of the way that nursing academically is structured might need to change. And that goes back to decolonization. I mean, we can decolonize nursing academics just like we can decolonize global health. I think there are, it's great to have these, reports from the Institute of Medicine, the National Academies of Medicine, talking about the future of nursing and talking about how we need to allow nurses to work to the full scope of their practice. And we need more PhDs in nursing. We need more nurse practitioners. But if the systems in which we're working aren't supportive of that, if nurse practitioners, if APRNs are still only going to be paid 80% of what a physician makes, if we are not going to be able to pay off our student loans, why should we go back to school to get a doctorate? So I think we need to be talking about all of those systems as well. And we need to be recruiting from populations that we don't see at the table. One thing that was really interesting the last time we met as a group was that there's no Latina representation on the nursing school faculty. So how do we get that? And I think that starts with how we're interacting with our professors on the individual level. I see racism in my classes right now. I'm a DNP student at University of Maryland at the School of Nursing, and I see my two Puerto Rican colleagues being treated very differently than the other colleagues are in my classes. And we should all be fostering each other. And I think nursing specifically has that stigma, which is unfortunate, of this lateral violence and this sort of eating our young, which also needs to be gotten rid of. And I think the way to do that is to also have younger people step up and foster and mentor the next generation to get into these higher positions in academia and in management and leadership within hospital systems. So it has to be a multi-pronged approach, and we have to look at all of the systems and how everything's operating.
Thanks for sharing those thoughts, Marcella. And it really, both of you, what you're speaking to is, and reminds me of what Dr. Nnodim Opara was saying earlier, is that systems will do what they're designed to do, right? And if we keep pushing the same things into the system, the same outputs are going to come back. So we really have to have, and what I heard you both say, we really need to have a structural discussion, not just band-aids here and there, tokenism here and there. We really need to think about the systems that are perpetuating these injustices. So thanks for sharing those thoughts, Felicity and Marcella. Now, Lindsay, I know you've been very passionate, and we've had conversations one-on-one in which you've expressed that throughout your education, you haven't really engaged with conversations like this. And the excitement that you were kind of telling me about was that this was an opportunity to rethink what PT physical therapy is. Why is this such an important moment to have this conversation? And I'm glad that you reached out to me and we were able to have that one-on-one conversation. Now, for the PT profession, the physical therapy profession, context is incredibly important, right? Context is actually something that PTs are really aware of. They have a really keen awareness of what the context is, because rehabilitation is not just about the person. It's also about the context. That is, attention to the built environment and thinking about the functionality and well-being is between the intersection between person and environment. However, and I think you mentioned this in our conversation, the very profession seems to still have some areas where they've not been able to look inward, right? They're very good looking outward, not necessarily very good at looking inward. Now, I know you're very passionate. I know you personally mentioned that you've thought that the profession needed to take a hard look at itself to build and educate for better physical therapy professionals. Now, can you share your thoughts in this regard? Tell us a little bit about your personal journey in this regard.
Can you hear me? Okay.
Yes.
Thank you for your question. I first want to say thank you to my brilliant summit team for being the blueprint to my addition to today's discussion, to my teammates Rogers, Caroline, and Promise from the University of Malawi, and my fellow PTRS mates Alyssa and Peyton. Thank you so much. So to address your question, I will be referencing a document my teammates and I created together to make sure that I capture the most important points of our discussion over the past weeks. Some reflect my personal journey, but most highlights our shared thoughts and experiences as PT students. So first, we found that analyzing the PT profession and incorporating this global health perspective reveals where PT practice is most vulnerable to inequity. Colonization and Eurocentrism contribute to significant deviations between the global North and South within our profession, whether it be historical exclusion of low to middle income country research and PT evidence, or the lack of prioritization of global health and PT education. Decolonization really begins with looking from within our profession, as you mentioned, and interpersonally, institutionally, and structurally to determine where implementation of global health is possible and how. So first, we talked about the models that we currently use to assess the entire patient in front of us rather than just focusing on movement impairments alone. So these include things like the ICF and biopsychosocial models. They're currently well-defined in literature, and we use them a lot in school and in PT practice. However, it's important to note that there are a plethora of other factors that determine how and why clinicians decide to use these models in their practice. Some of these factors include where they receive their PT education, globally, and at what institution? And within an institution, what do the educators value clinically? Because sometimes PT curriculums are tailored to what educators value as clinicians. And sometimes it can be a subconscious projection of their clinical bias. Also, how a PT has treated a similarly presenting patient in the past. So a physical therapist might be more likely to use clinical experience to determine primary treatment methods. And then last but certainly not least, research is super important in physical therapy. So what research is available, where is it available, and what research, anecdotally even, is known to be the most effective for certain patient populations. So the next part of the question that I want to talk about is diversity. So one of the most important aspects to the discussions related to diversity is that it greatly depends on social and geographical context. So even within one confined city or region, the needs of diversity can change significantly. So globally, the needs will vary even more when comparing country practices. For example, in my discussion with my team, we talked about the diversity needs in Malawi related to research and how it greatly affects their PT practice autonomy and the abilities for them to specialize within the field of physical therapy. So most of the research in the PT profession, like many healthcare fields, is done in high income countries, as mentioned earlier from other professionals, and in the global north, which leaves areas of our profession exposed and vulnerable to inequity. So implications of this that we talked about were that PTs practicing in low to middle income countries have less autonomy over treatments most relevant to patient needs in their region because other countries are deciding what the priority treatments within these regions are. Also, treating the patient holistically becomes increasingly difficult because the best available evidence, which is very limited, does not reflect the patients in that region where the research is being implemented. Also, the lack of research taking place in low to middle income countries makes it more difficult for other professionals to value a PT's role within the interprofessional team. So physical therapists often work within different parts of the workplace that involve talking to nurses, occupational therapists, speech language pathologists, et cetera. And so we want to be able to advocate for our profession, but we can't do that if the research is limited and the research is limited. So physical therapists need the local-based research, and it's very crucial so that we can advocate. So next we can compare this perspective to the diversity needs in our profession in the US. So here, the diversity needs are most immediately related to the lack of racial and ethnic diversity in our profession, especially within the field of physical therapy, since we are one of the least diverse fields in the global north in terms of race and ethnicity. On a larger scale, only recently have institutions and legislative bodies prioritized diversity in our profession on faculties and student bodies of professional education programs and in our field of practice. And so these efforts are appropriate. However, we need to ensure that institutions are not just checking boxes to meet quotas, including PT relevant education about why diversity and inclusion is essential, and education regarding the underpinnings of why there's a lack of diversity in physical therapy. And this is what could make decolonization possible, rather teaching the roots of these manifestations rather than just simply cutting the branches off. The issue here, though, that we discussed is that the underpinnings of decolonization can become highly politicized, which results in decolonization-related efforts receiving significant pushback in many areas of leadership in the field of physical therapy. So leadership boards and accrediting bodies that are not related to special interest areas may not prioritize this lack of equity as urgent or necessary. I'd also like to add that there are plenty of students currently enrolled in PT education who are still victims of microaggression and culturally insensitive behaviors at school and in clinical environments, despite the current efforts in place to avoid these and to include more racial and ethnic diversity. All considered, it was a bit challenging for us to know exactly what algorithms are used to prioritize components of PT program curriculums, nor do we fully know the priorities of legislative bodies that implement laws affecting our practicing jurisdiction, but we as students do see and live the immediate effects of current priorities of the higher ups. And with that, we kind of came up with a small list of potential things that we can do within our profession to jumpstart the decolonization of PT. So on a smaller scale, providing opportunities of exposure to global health from the beginning of PT education. This will provide students with early experiences with global health and therefore more opportunities to integrate this lens into our didactic knowledge. Also advocating to accrediting bodies about how global health education will advance the future of physical therapy in terms of awareness and global application of research. Hiring faculty who have experience or background knowledge in global health to make the integration of global health into physical therapy education more mainstream. And then I briefly have some global things that we can do that I discuss with my team. So creating more platforms like this for students and professionals to exchange dialogue on a global scale. I personally have learned so much about PT that I never knew from class or any other clinical experience that I've had so far in school. And I can imagine that students all over the globe can greatly benefit from this exchange and dialogue. Also prioritizing funding for local research to be conducted and facilitated by professionals and researchers on the ground of low to middle income countries, giving more local autonomy to clinicians. Increasing interprofessional awareness of benefits of physical therapy to other practitioners in settings where we practice, whether it be local or government run hospitals or in private practicing clinics. And then lastly, creating platforms for LMICs to share information and research about helpful treatments and practices they've found to be useful. Not only will this exchange increase the standardization of practice, but it'll also make us more culturally aware and competent providers. So that's what I have so far.
Thank you, Lindsay, for sharing those thoughts. And I really encourage you to try to write these down in a formal fashion so they can be heard by wider audiences beyond what is in here. And as a reminder, we do have a special edition of the Annals of Public Health, of Global Health, being published under this summit, a special edition on decolonization global health education that a lot of these panelists will be participating in. So thank you for sharing those thoughts, Lindsay. I really heard that it's not only going from the systems, but also the small actions can also add up to change and modify how we understand the profession. And I want to give a shout out to Dr. Tori Marchesi and Dr. Kara Felter, who really facilitated a lot of this conversation with students. And from the nursing group, I forgot to mention Dr. Nancy Bolin and Dr. Veronica Naikar, who have also worked with the students and continue to work now. Kind of, it's become kind of its own momentum and movement. So I want to move it on to the dental group. And for the people listening, I want to tell you that the dental group took a little bit of a different route and went ahead, and not only did they think about how learning should happen in global health environments, but they took like a leapfrog and said, let's do the learning right ahead. Let's see how it goes. And they structured a partnership between the School of Dentistry at UMB and Nihon University at Matsudo with the help of Dr. Hanai Saito and Dean Ogata at Matsudo and Dr. Kate Noonan at UMB. And what they did, they organized a peer-to-peer learning opportunity to try to establish how COVID has impacted dental education, and in the way, try to reflect upon how these educational partners happen, how these educational partnerships can be successful or not. So Ashraf, Jasmine, and Salataka, I know you've put together a small PowerPoint presentation, but mostly I want to ask you, what was the value of the collaboration between these two schools? Why is it important to set up global learning collaborations that are equitable in regards to the participation and the bilateral learning opportunities? So tell us a little bit about that.
If I may begin, thank you, Dr. Farron Guzman. I think the very important thing that we learned from our reflections and our discussions is that when we want to provide patient care, personalization is very, very important. And in order to personalize care and tailor our care to specific needs and cultural needs, lifestyle needs, it's very important to increase our awareness. So our collaboration with the students at Japan really helped us increase our awareness. It helped us gain perspective, not only on healthcare, but on many different cultural nodes. And so we realized the importance of expanding our horizons and creating more programs, whether it's educational, whether it's clinical, so we can do more collaborations worldwide. Because we have a diversity in the US, and even if it's not within the US, it's important to exchange information. We had a lot of exchange of information from Japan to the US and from the US to Japan. Equally great ideas coming from both sides. So I would say the most important thing is that we increase our awareness, as well as plan on future collaborations to tailor our care to specific needs, create personalized approaches, as well as to, approach everything from a global and very diverse perspective.
Jasmine, do you want to add something?
Sure. Thanks, Ashraf, for your insight into those questions. And in order to provide further understanding as to the importance of collaboration, I would just like to invite Ashraf to share our slides just a little bit, just to kind of provide more insight as to what we did. So we at the University of Maryland School of Dentistry worked in partnership with students in Matsudo to kind of deep dive into the effects that COVID-19 had on our curriculum. So here's our university, as you may all know, on Baltimore Street. Now, as you can tell, our education within the dental school is mainly simulation, clinical, and didactic based. So it all kind of comes together from year 1 to year 4. And these are our partners from UMSOD. And then also our partners from Nihon University.
Thank you, Jasmine and Ash. And our school is located in Matsudo City, Chiba Prefecture, and it takes about 30 minutes to get to Tokyo by train. In Japan, dental school is a 6-year program where the students start after the graduate high school. We used to focus on study abroad before COVID-19, and we are looking forward to resume the activity. And those are the participants from our schools. Thank you.
So in order for us to further analyze the comparisons and differences between our education here in the States and in Japan, we had various different learning objectives that we analyzed. And specifically, it did focus on the changes that COVID-19 had within our different curriculums. So our approach was various literature reviews, and then also providing a survey summit to all of the various participants, both here in the States and in Japan. And the analysis that we got, or the conclusion that we got, was pretty interesting. So this is the criteria that we kind of looked into. And the conclusion was that between our curriculum changes due to COVID-19 and the curriculum changes in Japan, they were pretty similar. However, we would all like to note that we wouldn't have been able to come to this conclusion without properly asking the right questions and having greater communication between both teams. More often than not, when we want to compare, sorry, my cat is driving me crazy. More often than not, when we want to compare from the state point side of view to international point side of view, we fail to have proper communication, and we rely more on assumptions than proper communication. So yes, between the States and Japan, there were pretty similar changes within the curriculum. However, we wouldn't have found that out unless we did the proper analysis. Unfortunately, I'm not sure if you can all hear video. In conclusion, we just want to thank all of our partners here stateside from UMSOD and also from the students at Matsudo. We thoroughly enjoyed this collaboration, and we had a fantastic time learning more about our curriculums and each other, and we hope to continue learning and collaborating in the future. I think that our little project really focused on the importance of collaboration, the importance of proper communication, and asking the right questions. You can connect it back to like humanitarian missions and things like that, where more often than not, we stateside want to provide help, want to do some type of change, but we don't often communicate correctly or ask the proper questions in order to see what the proper need is for those international sites. So by being able to collaborate in a very intimate way with the students from Matsudo, we were able to have a better understanding of their actual changes instead of just relying on assumptions.
I appreciate those thoughts. And again, kind of reflects on how collaboration happens, some of the challenges when collaborations are emerging, usually also when there's things like language and cultural barriers, but also things as logistical as time barriers. And I know we had a kind of a difficult time even coordinating the calls in preparation because of the time difference between Japan. So when thinking about global collaborations, the flexibility needs to be baked in. And I found myself taking calls at 4 a.m., 5 a.m., because that's what it takes sometimes. If you want to provide the opportunities, you want to elevate the voices, you got to really be flexible. And I saw a lot of that from your working group. So I really appreciate the work that you've done as students and the work that your faculty has done in providing that good framework for collaboration. Now, finally, I'd like to move on to our pharmacy group, and Janet has joined us in this panel to talk a little bit about how the pharmacy profession can benefit from a decolonial lens. And Janet, when we spoke the other day, you mentioned a good amount of things in which the profession could benefit. So I'm wondering if you want to speak to your personal educational process, and then how with time you've been able to look back and say, wait, there's some things here that actually need to change if we're going to talk about an equitable field of pharmacy, a decolonial field of pharmacy. But there's also things that we need to already start mapping in the forward, things around how research happens, R&D happens, the role of big pharma. So tell us a little bit about your thoughts in regards to the pharmaceutical or the pharmacy, the profession of pharmacy, and the decolonial lens.
Thank you so much for your question, and thank you for having me here. It's been really nice to hear from students of other health professions and just everybody's perspective. So thank you so much for that. In my pharmacy school career, I think that so much of pharmacy education and just health education overall can benefit from immensely benefit from having a decolonial lens. I guess some personal anecdotes that I could give would be around how oftentimes I noticed that in the pharmacy school education that I had and in pharmacy system in general, our current economic and R&D models, for example, like you mentioned in our call, they work against the traditional knowledge systems and non-biomedical health knowledge that we have. And this is seen in the way that most of R&D models focus on conditions and diseases that pertain to the quote unquote global north, but also in the medications researched. So for example, in my lectures on natural supplements, they often label them as alternative without acknowledging the traditional knowledge systems and often centuries long health knowledge that was in place. And while we know that studied nutraceuticals and practices are constantly changing because they're a reflection of consumer interest and what people are interested in. So now there's a widespread interest in several of these. So as an international student, having grown up with a combination of many of these remedies with what is considered Western medicine, it was just surprising to see, the hierarchical nature that was employed, where it was first Western medicine and then everything else was clubbed into this term as alternative. So I think that should be highlighted because, within the patient context and oftentimes the communities of color, it leads to this loss of autonomy of taking charge of their own health with, remedies that their cultures or their communities consider as just vital to the health of their communities overall. So I think that this practice in general is ethnocentric at its core, and so that should be modified. Another thing, I believe that cultural sensitivity is commonly mentioned overall in health education, and this is an important step. But in addition, I think that overall challenging the worldview that our education is informed by the dominant narrative, and acknowledging that the dominant narrative, even within the global north, is viewed as a default position, and that informs guidelines. And I think that Lindsay mentioned this before, even in PT, for treatment guidelines and information dissemination, what is the actual evidence that we consider credible is often within or often viewed through that dominant lens. So it's really, really important to mention this to students overall. And then I think that another thing that I think that in pharmacy education and health education overall, oftentimes deals with clinical tools and risk scores and risk assessments. And many of these are algorithms that, let's say, correct for race based on, that we recommend interventions according to US or, Western clinical guidelines. And then this determines what treatment patients receive, and then that has important implications in health outcomes. So we know that race is a political construct. So I think that pharmacy education and health education overall should move away from using race-based algorithms and treatment criteria. And a few universities have already accomplished this, so that would be important in my opinion. And the last thing, this also leads me to an important point in pharmacy education and health curriculum, which is a needed focus and being able to properly communicate information around racism, around bias and health outcomes in systemically under-resourced communities, not saying race is a risk factor for, and then actively having these conversations. Thank you.
Thanks for providing those insights, and I think that's very powerful. I just want to also highlight some of the things that you were mentioning when we talked the other day, and that might have not made your comments, but I did want to highlight that sometimes even the models, when applied R&D, right, will take quote unquote advantage of populations in the global south to do research trials, large research trials, right, and then those communities not necessarily benefit from those research trials and that exposure to that risk. And we've seen that even in the COVID pandemic. And Janet, you mentioned that in India, large clinical research trials were ongoing and within the pharmaceuticals and the different biological agents that were being tested. And then pharmaceuticals have not followed through with the distribution of vaccines in India. And we've seen the consequences of that play out in a very negative fashion as COVID-19 has broken the Indian health system. So there's also that we need to really speak of, because these are the future professionals that are going to be leading these trials, that are going to be leading these companies, that are going to be leading the conversation at a governmental level. And we really need to bring these things to fruition and make space for education in that regard. So I know we're a little over time. I leave with a lot of good notes here that I want to bring to the internal conversation we're having on Thursday. And to panelists, I just want to remind you that you are invited to participate in these thoughts. And I want to thank you all for this process that you've been engaged with in the last 4 weeks, in which you've been building up your insights and you're building up your different takes on this topic, and which is the culminating experiences today. So this feels like a culminating experience, and it really is for all of you. But what I want to say is, don't allow it to be the end. Do continue to push this conversation with your faculty. And I really want to send a shout out to all of your faculty. I didn't mention Dr. Dania Kato from the pharmacy school that has facilitated this and will be joining us in a panel briefly. What will happen now to attendees, and again, thank you for all the panelists and the students and trainees. What will happen now is we're going to take a short break, right, a 10-minute break, and then we're going to come in and we're going to welcome our Reactor panel, and we're going to ask them to reflect upon what just been said and borrow from their expertise and their experience to advance the conversation even further. So panelists, you're invited to stay around, turn off your camera and stay in the background, and then we'll invite now the panelists also to join. And for now, I'm going to call a 10-minute break, and we'll come back at 11:15 Eastern. So thanks everyone for staying online. I appreciate it. Hello, everyone, and welcome back. We're going to get started with a reactor panel. And the way we set this up and the way I wanted to explain how this will happen is I told the panelists, the reactor panelists, to think of this as someone just had a conversation, as maybe even a debate. And then we came in and we were kind of the CNN Wolf Blitzer crew, in which I act as Wolf Blitzer and I'm throwing questions around the table for a diversity of answers and thought processes. So right now, what I want to do is I want to welcome our panelists. I'm going to ask them to turn their camera on. Dr. Arguedas, Dr. Nnodim Opara, Dr. Cato, Dr. Seymour, welcome. And it's a pleasure to see you all. I've gotten to know you all throughout the year, some more recently, some more a little bit way back. And it's a pleasure to see you here, and I'm really glad that you accepted our invitation to react to what students were saying. I'm going to briefly introduce and read your bios or a snippet of your bio. And I really, again, just want to emphasize, if you want to read, for the sake of time, the panelists' full bios, I kindly ask you to go to the website. So first, I'm going to start with introducing Dr. Gabriela Arguedas Ramirez, who is an associate professor of philosophy and women's studies at the University of Costa Rica, my alma mater. And at the University of Costa Rica, Dr. Arguedas teaches bioethics, medical ethics, and feminist topics around many different angles. We also have, again, the wonderful Dr. Nnodim Opara, who gave us probably one of the best keynotes I've ever heard. And as you remember, she is an associate professor at Wayne State, where she teaches at the internal medicine pediatrics combined residency and is an assistant professor of internal medicine at Wayne State. So we also have Dr. Dania Cato, who is an assistant professor at the University of Maryland, Baltimore at the School of Primacy. She was a Fulbright scholar at the university in Palestine, at Brisit University in Palestine. So welcome, Dr. Cato, as well. And finally, we also have Dr. Seymour, who is a professor at the Department of Epidemiology and Oral Health Policy at the Harvard School of Dental Medicine. So welcome to all of you and all of our panelists, and thank you for being here. I want to start off by maybe getting a broad question out there and seeing if anyone had any initial kind of reactions they wanted to share. I know maybe I just saw Dr. Opara nodding, so I'm going to allow Dr. Opara first to come in and share her thoughts of what just happened, because I thought there was a lot of good things. There's a lot of, let's say, meat, hopefully plant-based meat, in what we just heard. So Dr. Opara, please take it off.
I'm not going to make a response to the plant-based meat business. Let's keep that one for offline, but I have thoughts. No. I just really want to, first of all, thank the students. I found them to be outstanding. It sounded like you all really took the assignment to heart. And I was very, very impressed by how much you put into working out the question, being very thoughtful and intentional around your processing, your analysis, and your delivery of the information. Just incredible breadth and commitment to it. And I know that it is something that you have internalized in a way that is going to inform the rest of your educational career and then your career even after that. So kudos to you for just an outstanding commitment to the work. I took a lot of notes, but I will be sort of, brief so I can allow my co-panelists speak. And then I think then I can add as we all go through the conversation. In the first group, I heard some really wonderful things. I'm going to pull out a few. I love the speaker who spoke about decolonization, meaning taking homegrown ideas to scale. And then another speaker in the nursing group talked about indigenous innovation, indigenous knowledge systems. And that's really the idea. How do we invest in indigenous knowledge systems and ideas and then scale them to solve, our own problems and answer our own questions. Inside of that, after that was mentioned, there was then continue, the conversation sort of moved from there, but I really want to bring thoughts back to that because I think there's power in that idea and start to push that group or that speaker to begin to think about, well, what will it take to begin to start investing in homegrown and ideas and indigenous innovations? What is now going to be necessary? What I find oftentimes, and I know that group was medicine, and for us in medicine, we're not well trained when it comes to systems thinking. We're not well trained when it comes to structural sort of, investigating or interrogating systems and structures and upstream causes. So I want to really lift that up and begin to kind of, I think a little bit of my role here will be to push. Like what all else will be needed to actually begin for that to happen, because it was almost conveyed as if, well, this would be nice, but anyway, let's talk about what is more realistic. And I want to start to challenge that sort of thinking of what is possible and what we've believed to be possible because we've been told that's what's possible. But is that true? And to begin to really allow ourselves to expand the possibilities through imagination of what will it take to actually solve the problems that we are grounding in bidirectionality or some kind of, them bring to us type of structure, because that's what we've always been exposed to. If we're going to dismantle systems of colonialism and colonization, it's going to require that sort of radical thinking in imagination and creativity as to what already exists that I can then leverage for us that begins to disrupt a relationship of dependency. So I would say that, and I think I've spoken a lot, and then I'll build on the rest, but I will lift up a couple of things so I don't forget. I also want to lift up, and this is for all the groups, is just again, as to push with love and kindness, is if we are going to decolonize, we are going to have to start with our language. And I want to really challenge terminology around repeating words like mission, repeating words like global north and global south, which is another term for developed and developing, which is again, what is that? And what is the frame of reference for what is development? And even the West, which speaks to this whole Mercator type, map arrangement and who sets the direction of what is north and east, south, and all that. Like, and can we just say what we mean rather than attach labels that we've inherited and that house hegemony inside of it, house hierarchy inside of it. And this is the push and the invitation that I will offer. And I will pause here and let my colleagues speak so I can learn from them as well.
Thanks for that, Ijeoma. And part of what I want to bring to the conversation is that, yes, decolonization is more just about reflecting, but there needs to be an action component. There needs to be an active component to change. So I know some of the things that were mentioned even in the panel, student panel, were around, this is not just about race, this is about geographies, this is about gender, this is about different intersectionalities that exist in this kind of work. And I know, Gabriela, you've done a lot of work in these intersections, and you as a feminist kind of philosopher, right? You bring these intersections clearly. So give us your insights on, in education, right? In higher education specifically, how do we do this? How do we combine intersectionality into our education work in a way that creates change? And I know this is what a lot of your work has been focused on.
Thank you. Well, I want to begin by giving thanks to this amazing organizing team and also to the students. I am amazed. And I am amazed also by the talk by Dr. Opara. I think that we are still trying to I don't know how to put it. I'm very, very emotional right now. I had this goosebumps when you were talking, and I'm still trapped in that emotion. Being said that, answering to Carlos' question about intersectionality, the first thing I want to say is that we have to be very careful not to use intersectionality as makeup. as just, something that the medical school, the nursing school, the pharmacy school does to have a better image, public relations. That's not the way to do it. So we need to be very careful not to say that we're going to introduce intersectionality in some of the curriculum, just as something that is added to the core, something that is adjacent to the real important issues. That's not the way to do it. And in the case of the University of Costa Rica, this is my university, that's what is happening, sadly. That gender issues, racism, xenophobia, homophobia, etc., are topics that are part of the narrative of the university. The administration is implementing, like in these public campaigns, saying that the university is against homophobia, the university is against racism, the university is against any form of discrimination. Big public relations campaign. But at the inside, nothing is changing. We are doing exactly the same, but with a very expensive public relations campaign. If that is happening in a university in Central America, I'm afraid that it's highly probable that that is happening also in universities in Europe, in the United States, etc. So students have a duty to call out that kind of deceit, marketing practice. Students are the ones who are more willing to make the establishment uncomfortable. And that is very important. We need to be uncomfortable. If we are very comfortable in our position, we are not making room for critical thinking, or even less for decolonizing processes.
Thank you for those thoughts. And really, as a Costa Rican, I also tend to agree with you that a lot of this is makeup, right? It's taking a very checkbox exercise, just ticking boxes. Yes, we're doing this, but there's no real integration into the conversation, into the curriculum, into the very structure and the policies that drive universities around the world. So, Dania, I'm going to pivot to you around this, and I want to get your thoughts on how do we go beyond just this makeup? How do we go beyond the tick box exercise that we see a lot of universities applying and institutions and organizations applying? How do we move the needle forward, walking the talk, talking the talk, and actually creating change?
Thank you. Thanks for having me. It's been an honor just listening in to you, Dr. Guzman, to Dr. Opara, to the students who, to be honest, I wish I could turn back time or turn forward time and be born, X number of years later to be able to be part of a program that's integrated into your training, because this certainly wasn't the depth of conversations that were happening when I was in pharmacy school, when I was doing my PhD in health services research, not even too long ago. So kudos to all of you, and I'm grateful to be in this panel. I did have some remarks that I think touch on what you've said, Dr. Guzman. I do want to briefly respond to Dr. Argudes' comment around, who ends up being responsible for calling out this performance, right? This performance of solidarity. And while we've often seen students being at the helm of social justice and demanding social change and transformative change at universities, I would actually argue that the responsibility is on leadership. It's on tenured faculty. It's on folks who are actually least precarious in these institutions to speak up and build solidarities together. And oftentimes those spaces of solidarity, what ends up happening is that these students who are organizing courageously for change end up having to rely on Black and Brown, primarily women faculty, who end up bearing the brunt of supporting students in this transformative change. So I want us to really think about power in this context as well, and who we lend power to and who we expect of taking the helm of this change while not acknowledging the power differential that's deeply, deeply woven into, at least from the perspective of myself as an academic, deeply woven into the academic institution of which we're a part. So I just wanted to say that as a thought. I do have some thoughts I wanted to share. As an epidemiologist, my work is focused on understanding cause and effect, right? The relationship between exposures and health outcomes. And often when we think about the causes of inequities or disparities, we look at the most proximal causes, those that are easiest for us to see. We might use this logic to say that low-income countries have low vaccination rates, the statistic you started off our conversation with today. They have low vaccination rates because of vaccine hesitancy, or corruption in the government, or low economic status, or incompetence even, instead of more accurately reflecting on the underlying root causes of these factors. So we use the logic instead that vaccine hesitancy is rather distrust, an actualization of a deep historical social understanding of the harmful role the global medical industrial complex has had on health in low-income countries. We may instead see low-income status itself as a consequence of not only deliberate disinvestment, but actually deliberate de-development. This is a term I borrow from the scholar at Harvard, Sarah Roy, who talks about the deliberate de-development and destruction and decimation of the healthcare system in Gaza and Palestine. These are important for us to understand because these are part and parcel of a pedagogy around decolonization. So it's not just a metaphor, right? We've talked about this, but the fact that it's not a metaphor is not where we end, it's where we start. And we begin to understand decolonization as this active process of dismantling structures of oppression within my field of epidemiology and health services research, but also the institutions within which we're a part, and of repatriating, okay, and repairing. And these are two things we have a hard time talking about. Repatriation, repairing, reparations, including through material and land return. That is the origin of the pedagogy, not just pedagogy, practice of decolonization in the context of settler colonialism. And I think it's really important for us to say this because it's important to actually weave that into our curriculums. It's important to weave that into our mandate as faculty, students, staff, and leadership who are actually committed to a process of decolonization and to moving beyond this decolonization is not a metaphor impasse. I did want to say one other bit. The students mentioned this really thoughtfully around the erasure of Indigenous knowledge. And I think it's really important for us to acknowledge that our institutions, many of them sit on the historic lands of the Indigenous people of this country who, especially universities, land-grant universities, including the University of Maryland, sit on land that was historically and settler colonized and became these big land-grant universities. So I think it's really important for us to acknowledge acknowledge that, not just in the form of land acknowledgements, but also acknowledge the type of erasure of Indigenous knowledge that happens at our institutions, the erasure of Indigenous people who are living and present, who are part of our communities here in Baltimore, the Piscataway people, the Piscataway tribe, and to think about how we can bring them into our conversation in not just in this token way, but in a way that really amplifies their voices. Finally, I just wanted to say, this is from my own personal experience. I've always been shocked, and I think you mentioned this, Dr. Opara, on how inadequate even faculty knowledge around systems and structural thinking is. And what ends up happening is I am often the first and last instructor that students are exposed to a structural analysis around race and racism, around power, around racial capitalism, around settler colonialism, and its impacts on health in Baltimore and globally. And I think that's something we really need to think about. How do we actually train our faculty to be better, one, in the pedagogy of that is required of a structural analysis, but to actually weave that into their coursework so that it's not just, you know, Dania's class in Epi at the School of Medicine or Dania's class in Health Policy at the School of Pharmacy, but it's woven into the curriculum and spirit of the curriculum at our university. I'll leave it there. I'm really grateful to be in conversation with all of you.
Thanks for those thoughts, Dania, very powerful. And I mean, I was a student myself only 10, 15 years ago, going through a University of Costa Rica medical program, and I never, ever learned about these things. So these are things that are systemic and universal almost. These voids of conversation don't only happen in the US, of course. And from a Costa Rican perspective, we never talked about things like social justice. We never talked about indigenous knowledge. We almost didn't even know that indigenous peoples existed. And I remember in my education growing up, I didn't even acknowledge that. It wasn't until I had these experiences working with indigenous peoples, working with public health professionals, that I managed to expand my worldviews and understand better that what was happening. So that if that would have been woven in better into the curriculum, I think that would have been really impactful. And how do we do that more? How do we advocate more for that? In that regard, I do want to bring Brittany's perspective here, because I know you've been an advocate to weave these things beyond just an elective, beyond just, you know, something that is one-off, then bubble in time, come, do, and leave, right? I know your approach has taken time, right? And now you've accomplished certain changes within the dental curriculum, even within a university, which is so, let's say, historically structured as it is Harvard University. So Brittany, tell us how about your journey, about the changes that you're bringing to curriculum and how you're trying to expand beyond just your university, but how do you bring change into the whole dental profession?
Okay, let me just give you my 5-minute response. So I'm going to back up a little bit. So I used to be a private practice dentist before I took this position. And my entire practice, my way of practicing, the way I was trained was in response. I'm an epidemiologist as well. And it was in response to a very classic model of what causes cavities. And I think this is a good analogy for what we're talking about. And perhaps the dental students, maybe others, might be familiar with this formula, this magic formula that causes cavities. It is bacteria, the bacteria that cause the cavity, and a sugar substrate, sugar, a susceptible tooth, and time. And when those four are present, that can lead to a cavity. And I mean, I think this formula was first discovered in the 60s, maybe earlier, and has just been perpetuated in the way we are trained. And that is a very micro way of looking at oral health. And so we and I have been working very hard to expand that model, and especially what is a susceptible tooth? And this is so much of what we're talking about today. It is not just a tooth in the mouth that hasn't had fluoride, doesn't have a sealant. It is a tooth in a human within a system where socio-cultural determinants of health impact this human, racism impacts this human. Historic structural violence has impacted this human. And so we are really working hard within our curriculum to broaden and redefine what is a susceptible tooth, and where this tooth is within this whole person, and where this whole person lives in their community, within their society. And so it's really taken us on this journey to think about, how do we view the health of our patients, within what context? How is that driving the way we're training our students and the way we're treating our patients in the dental chair? And so thinking about that, what is a susceptible tooth, and how do we move beyond this classic formula that I think is perhaps outdated now, and actually redefine our curriculum around this broader understanding of susceptibility to illness. So I wrote down 3 things I just want to touch on in reaction to the students and their really thoughtful vision for the current challenges and needs and the future direction they see that we should be moving. And the first is mental models. And we all function within our mental models that we have constructed and how we see the world. So for me, as a private practice dentist and clinician, my mental model included this kind of narrow view of susceptibility to illness, and I was reacting to patients within that narrow view. And we're now within dentistry. We have a long way to go in our profession, but we are deconstructing these mental models of health and illness and reconstructing them. We're moving beyond this kind of siloed curative approach and really thinking about and redesigning our approach to training our students in understanding our more holistic roles and responsibilities as dentists in the world. And the other thing we know about mental models is when we have blind spots, we fill them automatically, but only drawing from what we know. So we really need to expand our interactions, our own education. You know, I've been at this work a long time, but I continue to be humbled every time I'm invited to participate with students and others across disciplines, because there's so much that we still have to learn. The next term that I want to talk about is something we've heard a lot, especially in the US this past year: intent versus impact. And I think this applies a lot to dental students and to faculty and dental professionals. Our intent when we reach out to communities and provide services versus our ultimate impact. And not only is our impact not what we think it really may be during those kind of parachute models of outreach work, but there's really growing evidence to show that our impact is often more harmful in the long run. And this is, again, reconstructing these mental models of what our impact in our communities and through our volunteer work actually looks like, and learning. And then I'm going to build from what Dr. Opara mentioned about words, and that words matter. And I really do want to drive home that this word mission is still very much a normalized part of the lexicon in dentistry. I know that that's universal, but dentistry especially, you know, I'm on our admissions committee and I still see applications and personal statements talking about the mission trip they just did or the mission trips they want to go on. We have to stop using that word among many others. Mission is a direct relic of colonization. The mission was often tied toward providing healthcare as a concession for converting to Christianity. We must stop using that word. And in dentistry, we are very guilty of that. So as part of our curriculum, Carlos, that you mentioned, we are moving away from this idea of mission and really moving into experiential learning. We're shifting our own intent from intending to do good to intending to learn and better ourselves through our collaborations and our partners. So I'll stop there, but those were some of my immediate reactions and thoughts in listening to our students.
Thanks for that, Brittany. Really, really thoughtful, and I appreciate your kind of your differentiation from impact and intent. And I think it's important to have that clarity as you've laid out. I know I see some hands from our panelists, so I'm not sure who had it up first, but I'm going to give Ijeoma a chance to react. Maybe you wanted to react to something that was said previously. So please, the floor is yours, Ijeoma.
Thank you, Carlos. But I think Gabriela was put her hand up before me. Please go. No, please. Thank you.
Thank you. I just want to say before I forget, because not always my memory is working as I would like to. So before I forget, I would like to say that when we are discussing about decolonizing global health, or decolonizing healthcare, or decolonizing training in healthcare, we need to pay attention to the savior complex, or the white savior complex, but it's not always white. And I'm using this term by Teju Cole, writer Teju Cole. So we need to differentiate charity, good intentions, from the political process and ethical process of decolonizing. And the process of decolonizing puts the powerful part of the relationship at the center of critical analysis. Let me explain this. If we are situated in a university, in an Ivy League university in the United States, and we are having a dialogue about decolonizing global health, the critical perspective should be situated in that university, not around them, not in other countries or cultural settings. Because the first phase of decolonizing is decolonizing our own heritage, our own identity. And this is a very difficult process because it entails recognizing privilege, recognizing how, even if we didn't want to, we might have been benefiting from oppression, from exclusion, from inequality. And that privilege is embedded in our history, in our work setting, in our family relationships, etc., etc. That's one point. And the second one, I want to reply to Dr. Cato, because we need to remember that we are in a different position. And I'm speaking about Latin American movements, Latin American students movements that are very different from other students movements in the world. Latin American students are incredibly powerful right now, not in terms of power of dominion, but power for transformation, power for pushing the limits of what is happening in our countries. So we need to pay attention to what is happening in Chile, to what is happening in Mexico, to what is happening in Costa Rica as well. The feminist movement is mainly led by students, feminist students. And feminist students have put the University of Costa Rica under the spotlight in a very amazing way. So yes, of course, we faculty, we have a responsibility. I don't deny that. But I don't deny that when students come together and organize, they are unstoppable.
Thanks, Gabriela, for those thoughts. Ijeoma, please take it away.
Thank you so much. Oh my gosh, Dr. Gabriela, yes, so powerful. Dr. Brittany, just great to hear what you had to share. I've heard you many times and each time is wonderful. Dr. Danya, you just gave me, you know, we talked about goosebumps earlier. You gave me goosebumps, chicken bumps, pigeon bumps, all the bumps, okay? And you are so powerful. Thank you for what you shared, and you inspired really a lot of reflection and even connecting with what our wonderful students shared earlier. But I just want to lift up, look, the students are amazing. Dr. Kaiser said, sorry for the chicken bumps. I'll live. But you know, the students are wonderful, but you know that saying, the kids will be fine? The kids will be fine. It is the faculty, okay? It is that faculty development. And that is where we need to be really focusing on. And I love our students, and they are powerful and amazing and great, as we all have said, but I'm telling you, it is the faculty. And we have to be intentional in this work, in ensuring that we are bringing the faculty along. And there is a lot of things we can learn from the students in the area of courage, in the area of creativity, in the area of imagination, to think differently. It doesn't have to be one way. This scarcity mentality, I'm in academia too. So it is just, I mean, it is epidemic. And it's like, where does that come from? Why? And so what that also really struck in me, Dr. Danya, was, you know, when you talked about the structural thinking, and I had to learn that after I was done training, you know, and I had to learn that from experts outside of medicine, outside of public health. It was human, and the gift, and what I didn't mention in my story, the gift for me was that I majored in African studies as an undergrad. And that was a blessing. I started off as biology because that's what you're told to do as pre-med. And as I started to learn how to listen to myself and understand that I'm a woman of purpose and that I'm created for a reason, and I started to listen to the voice of my creator within, I recognized that I wasn't sitting comfortable inside of biology as a major. And when I read that first book, the autobiography, the interesting narrative of Olaudah Equiano, and I remember I ran to my dad. No, I was just talking to my dad. My dad is, I mean, oh my gosh, he's everything. And I was talking to him and said, hey, this is a book I'm reading. It's very fascinating. And he's like, and I said, it's the interesting narratives of Olaudah Equiano. He said, no, actually it's pronounced Olaudah Equiano. That is an Igbo man. I said, huh? Shmer? Igbo, slavery, how? And that's when I started to learn about the history, you know, what colonialism meant, the intersection of colonialism and the transatlantic slave trade, and how that, the whole story, and the whole shebang, and that I was located in that story. And then started to go back, but then what was there before? So I'm saying that to say that I love the way Dr. Danya said that. If you all, you know, get the recording of this summit, which I know you all will, just fast forward to what she said and just keep replaying it, because what she offered was so incredibly valuable in saying that we have to learn problem-solving thinking that moves beyond the proximal and starts asking those 5 whys. Root cause analysis. Okay, this sucks, but why? Okay, and then, but why? Okay, why that? At least 5 times, if not 6 times, to get to the root cause, and then begin to build coalition, begin to work together collectively to design and target interventions to the roots, not to what is proximal. Now, sometimes along the way in strategizing, there's some low-hanging fruits and there's some like short-term, goals that, sure. But always keep in mind the root, because without that root, like one of the beautiful, eloquent students said, that we just keep cutting off branches and they keep regrowing. We don't do nothing. The soil is the same, the roots is the same, the trunk are the same. In fact, the main proximal branches are the same. We just cut off, like we just prune the edges and we say we're doing something. So I just really wanted to lift that up and encourage folks to begin to really, and like I said, push, challenge yourself and each other hold each other accountable. So how do we begin to, what questions do we need to be asking ourselves to get to the root? And then how do we begin to talk about how we target the root in building solutions and ensure we don't forget the community is who is in the lead, not us. They are experts. They are the source of solution. They are knowledge containers, not us. That's speaking.
Thank you so much. I'm really honored and humbled that you found my remarks useful. I wanted to say, a few things that I feel like I'll cry at night if I don't say. And one of them is, it's sort of like an elephant in the room on a campus like ours, University of Maryland, Baltimore, which is this idea that there is a hierarchy that is assumed and accepted and internalized in medicine, and that is the physician is up top and everyone else is on the bottom. And I say this first and foremost as a pharmacist who has been disheartened to see what I think is pretty absurd erasure of the pharmacist's role in mitigating the impact of COVID. So you have health leaders, you have vice presidents and presidents thanking all of the healthcare workers by name except pharmacists. When pharmacists are the most accessible healthcare providers, at least in the US context, and I know often in low-income countries. And I think that's important for us to also understand this itself, this hierarchy is also a consequence of colonial mentality that has woven its way into our medical training. Not just our medical training, our practice, when we think of scope of practice laws. And so one thing I'm very committed to is, if not in practice, in pedagogy and flattening that hierarchy, to actually affirming the centrality of each of the healthcare providers in promoting care, not just to individuals, but to whole populations. So I think that's also part of this conversation that's very much relevant to our campus, but many campuses that have and teach medical professions. The other one is sort of related to this conversation around missions, and even in the term itself being a relic of the colonial past and present. And something I've often seen in my global health work and advocacy is this idea, well, it's better than nothing, right? Parachuting in, helicoptering in to this rural community in X country, it's better than nothing. We've done no harm. And I see that the same way I see this idea of mass dispensing of antibiotics as being benign and harmless. It's better than nothing. It isn't better than nothing. It's actually deeply damaging sometimes to an ecosystem of care that's being cultivated in these communities. It's actually a blank check to do often what the healthcare system may not even be allowed to do, or the healthcare system is struggling to do and to make long term. So I also want us to think deeply around this ethos of better than nothing, which I think is woven into a lot of these trips that students and faculty lead, and actually are worse than that nothing. They are actually deeply damaging and destructive to the long-term development of healthcare systems. So I just want to say those two pieces because they're relevant to our conversation and also speak to my own experience in this space.
Thanks, Tanya. I gotta accept and that I myself I'm a consequence of a system that is médico-centrista, as Gabriela just wrote in the chat, physician-centered, as my education never brought any real understanding of horizontal team collaboration. It was always in the form of a hierarchy, and inclusively in the policies that make up the health system in Costa Rica, that is incredibly clear. The physician is the boss. It's incredibly well scripted in policy. That's how deep structural things like this go. And I'm really ashamed that the first time I was working in a community, I thought that was the correct model, and quickly a very brave nurse put me in my spot, you know, and that was the first time I heard any of this. And that was after my graduation. How is this possible? You know, and how many people around the world are suffering the consequences of that? Mistakes that are being made in the name of medicocentristas or physician-centered approaches. Many times, as you were saying, the consequence of these gendered, these racist ideas. So thanks for bringing that. And it just really struck to my personal experience, and just wanted to say that I'm deeply ashamed that that's how my education brought me up. I want to ask a question, and you've been saying who takes the lead: faculty, students, faculty, leadership. You know, I think it's right. I think it's not an either or, right? It's always an and, right? But shed some light on what are some of the barriers. I mean, we need to understand the barriers that are not allowing us to advance, both at a faculty level, leadership level, curriculum level. Does anyone want to shed some thought into what are the barriers, and if you can, how do we overcome them? And then I'll try to wrap up with some positive notes. Brittany, please.
So I thought a lot about this all morning. And again, I'll speak to dentistry. Some of this is going to be more generalizable, but for dentistry, where's our incentive? We as a profession have done a really good job creating a nice life for ourselves that benefits the profession dearly, and developed very long-standing structures and fought hard against any effort to dismantle those to preserve the structure of our profession, which means far too many folks around the world don't access our services. So where is our incentive as a profession to start attacking these structures? Although not just from training, but motivation to go into the profession, the curriculum itself, what allows us to be an accredited, recognized institution. It penetrates all levels, and then how we maintain licensure across the spectrum of our careers. So, you know, it's going to take, I think, perhaps forced incentives or just changes in policies across this spectrum, at least from the perspective of the dental profession.
Indeed, incentives play, and we call this academic currency as part of these incentives, right? The publications, and how that creates pervasive incentives that don't allow these conversations to actually evolve. And just as one of the main academic incentives is publications. As someone that studied in Costa Rica, we don't have those structures in place. We don't have the research funding. We don't have. So when I was coming up and trying to become an educator, I felt that even like the ruler they were measuring we with was completely different, right? My work had been done in communities, implementing, innovating, you know, but I had very little or no publications. But it doesn't mean that I wasn't working. I just didn't have the structures that incentivize publications in place. And that took me a while to understand and to grasp. And now I'm luckily in a university, that an institution that understands that widely and has given other opportunities for professional advancement. But that's definitely one of them that I think needs to be changed and brought upon forward. Does anyone else want to provide some thoughts on the barriers, incentives conversation?
Go ahead, Gabrielle.
Very quickly. Thinking about my university, I don't know if other universities face the same problem. We are supposed to be in a university that promotes interdisciplinary, transdisciplinary collaborations and learning and teaching, etc. But again, it's into paper, not into practice. It's not put into practice for faculty, and is not put into practice for the students. So I think that maybe there's an opportunity to change and to take advantage of all the knowledge that is there for us and for everybody. And we need just to make connections, start talking to each other. How much interaction, how much dialogue happens between, I don't know, social sciences, history, anthropology, sociology, and the medical school, or nursing school, or biology, etc. It's impossible for us to know it all. It's impossible for the dentistry school or the medical school to have a faculty who knows everything. No? So we need to create a space of sharing knowledge, and to also make room to ask questions that can create also new answers.
Thanks, Danny. I know you wanted to say something, and maybe you can encapsulate what you want to say, and then some final thoughts, and then I'll go around the others to provide some space for final thoughts in 30 seconds, 1 minute, if you can.
Sure. Thank you so much. I'm speaking to your question around what are the barriers, and I think Brittany and Gabriella have gotten to them a bit. I would just want to put a finer point on something, which is that the ethos of the institutions within which we're a part center the commodification of health, and center this idea that healthcare is necessarily going to be driven by a profit enterprise. And I think one of the barriers to undoing, this global health system that is very much undergirded by colonial logic is to actually believe deeply that healthcare is a human right, and that all people are worthy of care, whether they're in the US. So you shared earlier this striking statistic about vaccination rate inequities. Well, we see that in our own communities in the US, right? We see stark inequities in not just vaccination rates. We see it in COVID-19. There's been a plethora of research that outlines this to the T, right? So I think the thing that the work, it's hard, is to also understand that it's going to be costly to undo these systems of oppression. It's going to actually be costly. And I mean this materially. It's going to cost money to dismantle those systems of extraction and exploitation that have benefited the global north. And I use this term because of the way it's understood. And if we don't have that kind of that move to that, an understanding of the way healthcare has been commodified globally, then we're less willing to take it on. So we saw this in the conversation of universal healthcare, right? It's going to be very expensive. Okay. What about the cost of not having care? What about the social, individual, familial, community costs of not having care? Why have we not contrasted that with the cost of universal healthcare? So I think this is sort of the elephant in the room, right? It's the commodification of health that people don't like to talk about, but it's really central to this conversation around decolonizing global health, because there are systems, there are institutions, there are people that are benefiting materially from these structures of oppression. And to decolonize means we uncouple them from that extraction and that benefit. And that's a lot of work there.
Thanks for that. We count with your support in this endeavor. So we're really appreciative of having you here. Ijeoma, please.
Yeah, sure.
Final
really
thoughts.
Yes. Yeah, and absolutely. I think my colleagues have been very eloquent on this topic, and it's a great question that encapsulates the intersectionality and mutual reinforcement of these systems of oppression, right? So Dr. Danya has talked about pretty much capitalism, without calling it by name, and how capitalism is intersecting with, again, these colonial structures, and they absolutely need to mutually reinforce each other. That's how they've always worked, that exploitative, extractive process. And that shows up not only in the commodification of healthcare and then all the ripple effects of that, but it also shows up even inside of your question, Carlos, about the barriers for faculty and students. And I can tell you, as a full-time clinician, who is going to be running to clinic immediately we turn off the camera, right? I'm not compensated for this work. I'm not compensated for the teaching and for the mentoring. And I mean, it's part of my professorship in the School of Medicine, but that's a title. But really my job is to make my, the school and my department money by seeing patients. And so talking about elephants in the room, that's definitely one of them, sitting on the other corner of the room, right? Is that if our and Dr. Seymour has talked about it as well. So therefore, shout out to all the Black women, that usually, as has been said, that do this sort of work, mentor everyone, do multiple projects, out here speaking, agitating, advocating at great risk to self and reputation and income, right? Just because it's right. It's like what Dr. Daniel said, because it's the right thing to do, because it's our family, because it's our grandparents, it's our children, our grandchildren, it's our cousins, our brothers, our sister. It is us. And we are out there. And honestly, I'm not asking those questions. It's hard for me to even process barriers and incentives, because we just do it. And yes, it's not right. And it's not easy, because the system is unjust. And so it makes it incredibly difficult. And there are multiple layers to that. But honestly, we just do it. And so I think once we agree, I think, we are at a crux at the end of the day, as a country and as a world. Who are we gonna be? Who are we? And once we agree on who we are, then we need to then have the courage to then make that vision come true and deal with the resistance when they come. And sure, there is some strategizing and wisdom applied towards understanding what those resistances are and those dynamics, absolutely. But it really does come to, and Carlos, you said this when we were in Costa Rica last year. You said that Costa Rica said, this in terms of the healthcare system, and you have universal healthcare. This is what's right. Universal healthcare. So you know what? We agree. So whatever it takes to get there, we'll do it, but we have to just agree. This is what is right for us. And that's the conversation we need to just come to. And so the barriers can come in whatever shape or form they like. We'll deal with it, but we have to agree on who we are and what we're willing to do to make it happen. And the responsibility lies in those that have the most power. It lies in institutional leadership to make decisions as it relates to funding structures and the budget. It absolutely lies on how the institutions invest or divest, and sort of these larger conversations. It really does, because the kids are going to be all right. I mean, I mean that with due respect. These are adults, and with much respect. So pardon me, but our young people are going to be all right. But it's those folks holding the keys to the locks that need to have a come to creator moment on who are we and what legacy are we going to leave in terms of the world. So that's really, I just wanted to lift that, I think. And then very, very quickly, because I want to shout out Wayne State University, we are having those conversations in our institution. We're setting up awards. We're setting up annual reviews for promotion that will ask questions around what are your activities around JEDI, justice, equity, diversity, and inclusion, and belonging. We're setting up awards that honor and recognize that. I've had conversations, and my leadership has come to me, even without me coming to them, about how can we support your work by providing protected time. I really want to honor that, because you don't get that everywhere. And so these are some ways that there can be some liberation, shall I say, built into the system to create the space for our faculty and students to do this work in a meaningful way.
Thanks, Ijeoma. Thanks for those final thoughts. Brittany, please try in 31 minutes. Can you give me your final thoughts? We're a little over time. Just trying to be mindful of the next panelists.
I suppose I'll just think about, you know, I often, especially early on in my course, when we're talking about the scope of the challenges ahead, I see a lot of cynicism building in students, which I want to be cautious around. And so I really work to actively build from those seeds of optimism that we see through this idea of hope. And there's a lot of actually academic work around the concept of hope. And Duncan Adrad did a nice body of work around hope and moving from mythical hope, this idea of words on a page, to critical hope, where we actually instill in our students, our faculty, hope based on the success of our actions, large or small. And so I tend to really look at where can we identify a success, build from that, instill hope, and utilize that as a tool for continuing to move ahead.
Thanks. That's brilliant way to end. Gabriela, please, some final words and to take us home.
I just want to say thank you again. Really amazing, inspiring, and that's it.
Great. No, thank you. Thank you all. Thank you, Gabriela, Dania, Ijeoma, and Brittany for the panel. Thank you for the people that have stayed on and listened to these very, very powerful conversation. It's a real honor to be hosting this panel and be in the presence of these great professionals. And I have a lot to digest. I think we'll in the afternoon, I'll be very restless trying to get some ideas on paper and trying to bring those ideas to further the conversation. So thank you again. This was a really amazing panel. I'm going to ask the next panelists to jump on. I think, Lauren, you can bring them in with the crane. And Dr. Sangaramurthy and Courtney Jones-Carney, if I see Thurka has jumped on. Gabriela, Brittany, Ijeoma, Dania, thanks again. It's been a pleasure. And now we have the present. Excellent. Hello, we have Dr. Sangaramurthy joining in from Addis Ababa, if I'm not mistaken, from Addis, right? And then we have Courtney Jones-Carney joining us from University of Maryland, Baltimore. I think she's in Baltimore. So please take it away. This will be a dialogue between two experts, one looking at diversity, equity, and inclusion, the other one looking at decolonization in education. And it's going to be a wonderful conversation. And the idea is to get some of these similarities, differences, intersectionalities between these two topics, and how do we then incorporate that into one solid strategy. So it's not a diverse group of things happening in parallel, but how do we converge in our agendas? So thanks again to both of you for agreeing to do this conversation, and I leave the floor to you.
Thank you so much, Carlos. Good afternoon, everyone. Thanks for being here. I'm Courtney Jones-Carney. I'm an executive director at the University of Maryland, Baltimore for intercultural leadership and engagement. I'm also the director of the Intercultural Center, and I'm the programs director and faculty in the Intercultural Leadership Certificate. So intercultural is all over, it seems like, everything that I do. Before we get started with the dialogue, I wanted to allow Thurka to introduce herself and provide any information to the group that's here.
Just sort of a general introduction. Yes, okay. So my name is Thurka Sangaramurthy. I am an associate professor at the University of Maryland at College Park. I'm a cultural and medical anthropologist, as well as an epidemiologist by training. My work broadly sort of looks at power and inequities in various different economies of care. And I work at this intersection in 3 different areas, mainly in HIV disparities, as well as STD or sexually transmitted diseases disparities, migrant health, as well as environmental justice and environmental health. So those are the three main areas that I work in. I also teach on global health and have been doing a lot of work around thinking through how to re-envision global health education using different types of pedagogies, particularly around decolonization, anti-oppressive, and anti-racist sort of pedagogies.
Wonderful. Thank you for that. And so before we dive into our dialogue, I just wanted to share that I enter into today's talk in a pretty somber mood, recognizing the need to call attention to the ways that white supremacy impacts policies and practices around the world. And so hopefully many of you that are listening, you understand what I'm saying when I use the term white supremacy. And so I'm not solely talking about individual or group actions often associated in the US with the Ku Klux Klan or neo-Nazis, but instead I'm referencing the upholding of whiteness or Eurocentricity as the everyday norm or the standard across various societies. And so white supremacy centers assumptions of superiority of people defined or perceived as white or of European descent, while simultaneously centering assumptions of inferiority of those defined and perceived as Black or of African descent, while positioning all other racial and ethnic groups across the world closer to either whiteness or Eurocentricity or Europeanness or Blackness and Africanness. And so as we enter into today's dialogue of re-examining the assumptions and practices underpinning global health education and practice and the intersection of advancing diversity, equity, and inclusion, I also want to acknowledge that 1 year ago today, on May 25th, 2020, this may have been mentioned earlier today, George Floyd was murdered. And his murder was recorded and subsequently broadcasted across the world, reigniting and in some cases igniting a national and international recognition of the Black Lives Matter movement. So today may be a difficult day for some of us. We may find it difficult to be productive and engage, to meet our personal and professional goals for the day. And so I want to encourage people to take the time that they need to honor the life and the memory of George Floyd and to reflect on the desperate need for systemic change in policies, practices, and also the educational process that many of us have come up in. And so that brings me to our first topic, which really is about how you define decolonization and what connection you see, Thurka, between decolonization and diversity, equity, and inclusion work.
Thank you, Courtney. I really appreciate the fact that you brought up George Floyd's, the anniversary of his brutal murder. I think that's really important. It also helps me sort of situate where I am as someone who is living and working in Addis Ababa in Ethiopia in the middle of huge civil unrest. And so I really take to heart some of the difficulties in proceeding with work as normal, right? Especially in these instances for many of us. So I want to kind of start, and I really do hope that it's a conversation between us, Courtney, in terms of decolonization. And so, you know, I think many scholars, especially Indigenous scholars, have really talked about what decolonization is not, because it is something that is really, really difficult, I think, in some ways to define. And even the definition in itself, right, could be sort of seen as inflicting harm and violence. So scholars have talked about the fact that decolonization isn't just sort of simply converting Indigenous politics, right, into our understanding or Western understanding of liberation. It's not necessarily just about helping people who are at risk or those who are suffering. It's not a generic term, right, for social justice or for struggle against sort of oppressive conditions and outcomes. So I think social justice can actually have room for all of these kinds of efforts, but it's really decolonization, if you want to look at it from more of a purist term, it's really about repatriation of Indigenous land and life, right? It's not something that you can just sort of put in as a metaphor, for instance, for social justice, right? So I think that's really important to sort of understand. It's also important to understand that decolonization or decolonial struggles can mean different things. So in the US, right, settler colonialism is very different from something that is happening in many places around the world right now. So these struggles are not necessarily, parallel. They're not even shared equally, and they're not things that can sort of neatly sort of bring any closure, right? It's not like you have decolonization and then everything is sort of back to normal, right? It's not equivocal to anti-colonial struggles, right? But it is really connected to anti-imperialism in other places around the world. So sometimes, it's really easy, and I know we're going to have a conversation about sort of decolonizing global health, right? But I think that without sort of making mention of Indigenous struggle around sovereignty and the contribution of Indigenous intellectuals and activists around decolonization, I think that's where, we have to sort of center that work when we talk about decolonization. So I wanted to sort of say that, but I think that, one of the things to think about when we're talking about global health in particular is that global health is neither global or diverse, right? Racism and white supremacy are major issues in global health, and it continues to drive population as well as individual level kinds of inequities in health on a global scale. It's often delivered, right? The people who are on the ground are often women, but the field is often led by men. You do have Western or high-income countries that dominate almost all aspects of global health and the global health enterprise. So, I think that these are sort of questions that I wanted to kind of bring around decolonization. But I think, one of the other things, I want to mention is that it's also about the institutions in which we sit when we talk about decolonization, right? Both of us are at the University of Maryland. We are a huge land grant university system. The more where we come from, I know we make these sort of, land acknowledgements, many of us do, but what these statements often miss is that institutions like ours are not just built on Indigenous land, but they were built with Indigenous land, right? The Morrill Act granted, Indigenous lands to states to actually fund universities like ours. And these were often raised, they often raised money for college endowments. And so, all of these things have to be taken in, not just sort of in a broad sense of global health, but in places that we sit, places that we work. What is at stake here, when we talk about decolonization?
You said a lot. And I think the last point I'm kind of honing in on is just thinking about that Morrill Act and how that was used as this tool to shift from this collectivism culture to this individual culture. And so really shifting this need for ownership for Indigenous folks to individuals so that then land could be grabbed by the US and then utilized at will, instead of having like this collective culture where folks are taking care of one another and are feeling a connection, not ownership, but a connection with land. And so I feel like that is a huge point that's probably missed by many as to how land is, utilized, specifically as we think about higher education and the spaces that we occupy and build upon. And so, I
I love it. It's great.
Yeah,
there's so much to think about here. And so it becomes really difficult for an institution to even proactively think about how do you decolonize when you are in this, especially in the US, when you think about settler colonialism and that folks are still here. Folks have created the policies and the practices that impact folks across all levels. And so, there is going to be a huge monetary effect in order to really decolonialize all systems across the world. And so if we can talk a little bit about perhaps how do we do this in the curriculum? And so I was looking at, there was a nursing text that has been pulled by Pearson, but it specifically talked about like teaching future nurses how to engage patients about pain. And so there was a lovely chart that was presented in this book that stated, okay, if someone is Arab or Muslim, this is how they are going to react to pain, right? And so stating that individuals who are Asian are pretty much going to be stoic about pain, and they've been conditioned not to respond verbally about pain. Folks who identify as Black are going to report higher intensity of pain. Individuals who identify as Indigenous in the US are going to want medication that has been blessed by a tribal shaman. Folks who are Jewish will be vocal and demanding. And so in this text, it pretty much created these assumptions about individuals and then training nurses about how to respond, but not responding about what an individual is telling you, but more so about stereotypes that then have been formed. And so how do we work to decolonize the way that we're teaching when sometimes these are seen as best practices, creating stereotypes and informing folks of how to respond based off of stereotypes that individuals believe to be true?
So you bring, I know this text actually really well. So, it's interesting that you bring this up because, as a cultural and medical anthropologist, right, a lot of the work that we have done around culture, right, and how culture really impacts health has been really taken up in ways that I think that many scholars in anthropology did not intend to, right? And this notion around cultural competency is a great example of when individual identities, right, are then layered upon these notions of cultural identities, right? They're not just about individuals, but then they are scaled up at the level of communities or groups or ethnic identities. And then that becomes sort of reinforced with already existing stereotypes that we often have of these groups. And I'm not saying that these are texts or ideologies that are, mean-spirited, in a sense that they were not really designed for that. But what they have done is that they have, as you said, they have really stereotyped people into these little sort of, boxes, right? And it's almost as if we are only operating on individual sort of characteristics, when we know that as human beings and as an anthropologist, I need to say that we're more than just individual identities, right? We are always, as human beings, located in sort of a matrix of power, right? And so you have to understand, structural issues. You have to understand that medicine and nursing and health fields also have a culture, right? It's not just individuals, and particularly people that we think about in terms of who has culture, right? when I ask this question to my classes, right, or my students, it's always really interesting about who we think has culture, right? Do white people have a culture? Do nurses have a culture, right? And so oftentimes this notion of culture in itself becomes highly problematic, right? It becomes sort of a location where we sort of talk, you know, when that's sort of seen as something different to what we might call knowledge or scientific knowledge, right? It's almost the opposite in that sense. And so knowledge exists, right? Or scientific knowledge in this case exists at, you know, within the field of nursing. And that is sort of something that we really can't talk about because it exists. It's objective, right? You know, but the patient has culture, right? In this sense, the patient has culture, and that's just something that nursing or any health profession just has to sort of incorporate and understand and move on. But without really understanding that scientific knowledge in itself is very cultural, right? It is a particular kind of culture and needs to be addressed as such. And more importantly, you know, it's really important for health professionals to really understand structural issues, systemic racism, you know, all of these things that really impact not only who that patient is when that person comes into a clinical space, but it's also about the relationship, right? That is inherent in sort of a positionality between, you know, power and privilege. That happens in that room between the provider and the patient. Even this notion of a patient in itself is hierarchical, right? As if they don't have knowledge, right? They just have beliefs. And there's this oppositional framework that often gets constructed between knowledge as something that is incontestable because it exists, you know, in some real space, but belief is something that just needs to be, you know, overcome and maybe understood. So I hope that that sort of makes sense. And I think it gets to that question that I think you're also asking around classrooms. I'm sorry, I tend to talk a lot, but the classrooms, but it's about sort of, you know, this enters into this space about what we consider to be respectable forms of knowledge, right? And as you brought up, there's a course book, there's a text, but it's also about what nurses are supposed to think, what medical professionals are supposed to think, how their knowledge is often sort of privileged over all else, right? And so I think we can have that conversation if you want around sort of, you know, moving into classrooms and curricula as well about what kinds of things that it privileges.
Yeah, I do want to talk about that. But before we do that, I wanted to go back to this, what is culture, and like really thinking about the culture of a particular profession, the culture and the history and the legacy of inclusion and exclusion within a particular profession, and how folks have to reconcile that while they're in their profession. And I think it becomes really important for people to think about like what has been the historical impacts, positive, negative, in my particular profession, and how does that impact the way that I learn, the way that I interact with folks, the information that I trust, you know, how I position myself when I am meeting with folks who are, you know, referred to as clients or patients. And, you know, I think that that becomes extremely important in building that relationship, is understanding what sort of experiences individuals and groups may have had within your profession that may make it so that you really have to work to establish the trust and to acknowledge that there has been wrong that has been done in this particular profession that may have impacted you. And I get that, and I acknowledge that. And this is what I'm doing to try to make sure that you're receiving the care that you want to receive. So I think it becomes really important for people to understand that history and that legacy of the profession that they're in. Do you have any additional thoughts on that?
Yeah, I mean, you know, I think that you had, I know that when we had a previous discussion, there was this notion of disciplines, right? when you think about the notion of discipline, right, you need to understand what that word actually means. Discipline's discipline, right? And so it's this notion of how our professions or our disciplines, however we want to sort of call it, how those things are really indoctrinated into a particular sort of realm of thought, particular kinds of ideologies, particular ways of even professionalizing us, even that word of professionalization, what does that sort of entail, right? So all of these questions are really important. I am someone who sits in a department of anthropology. I'm also an anthropologist, right, by training. My profession or my discipline is inherently colonialist, right? That is how the discipline came about, was to serve colonialist sort of, expansion and destruction and violence. It was a discipline that was born from that. The methods that we used, right, were used in those times, right? So these are really important, and it can be very deeply uncomfortable for folks of color, right, to be in these spaces. Because they have a way, and disciplines, right, are really meant to be reproductive, meaning that they reproduce. And they reproduce through scholarship, they reproduce through training, they reproduce through education. And so sometimes these are really uncomfortable spaces, but there are some of us who are trying in whichever way to sort of rethink, right, and to build something that might be slightly different, but without sort of that acknowledgement, without that recognition, I think that those things need to happen.
Yeah, and so this idea of scholarship, I have a podcast through work, and so we talk about social identity, and I feel like it's very informative. I think that it provides a form of scholarship. It contributes to a body of work. But it probably isn't recognized as scholarship, even though there's a great amount of research that goes into it, and thought and planning that takes place in creating the topics and curating the messages that are shared. And so, perhaps like thinking about like what sort of knowledge sources are respected in higher education, and how that impacts the sort of education that students are receiving, and how they are then, trained within those disciplines to then reproduce what the discipline has stood for years or centuries, or, so on.
So I can talk a little bit about perhaps what it looks like for me. And I know others have written about this and talked about it. So I'm just going to kind of make this a little bit personal as well. And so for me, this question of knowledge really sort of, I come to it, right, very late in my career, unfortunately, in a sense of two sort of interconnected forms of pedagogies for me. One is a decolonial pedagogy, and the other one is something that's what I would sort of think about as an anti-oppressive pedagogy. So, and for me, they work together, right? For me, they have to work together. I know I can do one without the other, but I really believe in the intersection of both of these. So decolonial pedagogy, at least for me, really, you take from your point of departure, right, that this traditional canon of many academic disciplines, including the health profession, has been extraordinarily violent in its exclusion of Indigenous and non-male and non-white and non-Western and otherwise marginalized voices, right, point blank. So this pedagogy requires me, right, as the instructor, by setting that historical context of colonial relations around power and privilege, it's critical to understanding where we are now. Without understanding that context and without understanding where that discipline is coming from, it's really difficult to arrive at the present moment, right? Looking at that text that you just brought up. It's hard to do that without really setting that historical context and understanding what your discipline has done, right? It's also about centering on Indigenous and marginalized voices that are, and concepts that have and continue to be silenced. Exposing students to critical thinkers, right? Knowledge producers who've been central to the development of disciplines like nursing and anthropology, but who have been systematically unrecognized for their work. It's a process that goes deeper than just diversifying the syllabus, right? It's really about helping students learn to identify and critique patriarchal influence of white and Western conventions of the discipline, and also developing tools for their own sort of journeys, right, into anti-colonial pedagogies. You know, fundamentally what I ask students to do, and what I think is really useful, is to really ask students to rethink this rethink this category of knowledge, right? What forms does it privilege? Who's credited for the production of knowledge? Who is considered a knowledge producer? How can you center Indigenous and sort of marginalized ways of knowing and understanding the world, right? So when you center on these things, your syllabi and your classroom experience does not look the same. And this can really throw off students a lot, because oftentimes this is not normative, right? This is not the way that we're taught to learn. I was never taught to learn this way. And so an anti-oppressive pedagogy goes hand in hand, for me at least, because it's about sort of examining existing systems and combining information and values that are not taken from sort of written English language, peer-reviewed publications, right? But really, the value really is taken from the lived experiences of a range of people and contexts. So this involves recognizing that the typical ways of doing things in academic institutions are not universal, right? They're not universal. They're actually based on white values and often ableist assumptions, right? But we treat these norms and standards as if they're objective, as if they're unbiased, if that's just the way that it is, you know, and frankly, superior to doing other ways of thinking, you know, or doing things. So, you know, I talked about professionalism standards, right? Perfectionism, individualism, quantity over quantity, you know, quality, priority over the written text. They're all examples of this, right? These are not normative in many places around the world, or to even any one of our experiences, but this is what gets prioritized in higher education, in these classrooms. And so you need to sort of start breaking these things down. So for me, you know, what you're talking about, I love podcasts, but like, you know, it's hard because some students, I don't know, there's a huge leap that happens, right? So you have to offer, like for me, I offer multiple modes of engagement. So it's actually, I use very little sort of peer-reviewed publications, right? I use text, I use media. Some cultures or communities are entirely orally based, right? And so there's lectures, there's other ways of engaging, right? Some students are visual learners. I'm a visual learner, so I tend to use media a lot, or visual media a lot. You know, giving students choices is also really important, right? If we want to really decenter our own power and privilege, you know, and thinking about knowledge, it's also about giving students options. It's about exposing them to whose perspectives are represented or not. It's about being flexible. You know, it's offering them various ways of thinking about their work. So it's not about introducing them to different kinds of engagement, right, through text or media or other forms, but it's also showing them that they can be knowledge producers in these various mediums, right? It's so much more enjoyable for me to teach when I teach in this way, because you know, I have students, you know, I taught a global health class, you know, it's a larger class, it's, at least for us, it's 60 students. The final project is a multimodal project, meaning you can use any kind of mediums to talk about a global health challenge, right? I have students who do paintings. I have students who do comic strips. I have students who do podcasts, webinars, you know, interviews, you know, I have students who do sort of information-based kinds of written text. And for me, I don't know. I find this to be just so much more engaging and enjoyable to even read and to assess, rather than sort of sitting in front of, you know, a paper, for instance. So, you know, I think these are some of the ways that I sort of approach this.
Yeah, thank you for that. As an instructor, I also find it interesting, and I enjoy when students send me a video instead of writing something down. And so I think that offering and encouraging those different forms of medium for sharing knowledge is extremely important. And so at the University of Maryland, Baltimore, in the School of Social Work, this academic year, they launched a mandatory class of structural oppression and implications for social work practice that all of their foundation first year students had to complete within that first year. And I think it gets at some of those ideas that you talked about, but there still is going to be need to further develop and evolve the course and ensure that the publications, the items that they are reading or viewing aren't just peer reviewed, don't just position folks to understand what it is like to perhaps be a white social worker who's providing services for BIPOC populations. Just like in all of those professions at the various schools where we are employed, it becomes important to ensure that the resources aren't teaching folks how to be white professionals providing something to folks of color. And quite often, because of this idea of the standardization of norms and who has culture and who doesn't, and whiteness essentially just being absorbed into the air, right? And that just essentially becoming the culture with being this invisible culture that people don't necessarily see or feel or really talk about, then it positions folks to perhaps be trained to approach the work as if they are white, providing services to folks who are folks of color or lower SES, but not really taking this, really holistic approach on what it means to provide care if you are BIPOC and you're providing care to someone who's white or someone who's low income or someone who has higher socioeconomic status. And so really trying to create a space where folks can understand how different identities are going to function and provide services, receive services, and then be educators and teachers in all these different realms. And so, sometimes, specifically as we think about these different forms of knowledge, particularly as a professor, as faculty, there is this idea of publish or perish. And so thinking about that phenomenon and how do faculty members potentially balance the pressures of publication while advocating for other forms of knowledge sharing to add to their field? So how do folks balance that need with also balancing their desire to be tenure, to receive salary increases, to meet their needs, all of those sort of things? How do folks balance that? How have you balanced it?
So this is a really difficult and complex sort of conversation, right? I think that the academy has very specific sort of evaluative standards, right? That absolutely is based on certain forms of knowledge, right? And certain privileging of knowledge, right? So whether it's grants, whether it's publication or written text, whether it's, certain ways of teaching, right? That then engender particular kinds of evaluations from students, right? That are also these metrics around quantification without really taking into context the various ways in which these relationships between professors and students sort of occur in that classroom, right? What students are sort of professionalized to sort of understand as what happens in the classroom. And so, you know, these things are really, really difficult to sort of, especially as, so again, you know, my personal sort of experience is that, you know, I work in a lot of community engaged work. I have mentors who are community members, right? I don't have just academic mentors. I have community members who are my mentors. For me, my scholarship, and I know for others, my work and my life are not two separate sort of entities, right? They're kind of one and the same. And so who I am as a scholar is who I am as a person. I undertake projects because they're deeply meaningful to me and they matter to the communities that I work with, the communities that I'm part of. And so, so sometimes it's really difficult to merge these two kinds of things. And so it's not just about sort of the academy, but it's also just about, you know, it's not, if we want to be real, it's not really a space that fosters, right? Activism, advocacy, these kinds of engagements, right? That don't have a specific kind of metric in the way that we can be evaluated. So that is really, really difficult. For me, I've tried to learn, I think for many, most of us navigate both of these positions, right? Sometimes at a huge cost. Sometimes your community commitments suffer because you have to sort of focus on getting tenure, you know, whatever kinds of evaluative measures there often are. For others, for where funding is really necessary, sometimes it doesn't engender that kind of work, right? Because you're writing for grants versus others. The things that you can publish, for instance, that's another sort of issue, right? So there are all these kinds of metrics. I think, you know, at some point, it really depends, right? You know, as a graduate student, for instance, it's really different. It's really different. I mean, you're sort of in a system and you have to sort of pass that system and you have to put up those metrics, right? As someone who's an untenured faculty, for instance, right? Those metrics are also really sort of heavy in a sense that you have to get through that next stage of tenure. You know, some of us, you know, spend, I guess for me, a lot of this work has happened post-tenure because there's a slight difference in freedom. It doesn't go away. Those pressures don't go away. That's not what I'm saying. But it gets slightly easier, right? In a sense that you have a little bit more freedom. For me, for instance, a lot of my work is now policy oriented in ways that it wasn't or couldn't be before. A lot of my work in HIV in particular is entirely public facing, meaning it involves multimodal sort of ways of thinking and engaging with the communities that I work with. So this is sort of, you know, partnering with, you know, and trying to launch a national storytelling campaign, for instance. You know, these are not necessarily metrics that fall, and I have been told over and over again, sometimes this isn't scholarship, right? But this project in itself, for me, it doesn't matter. It's absolutely in service to the communities that I work with. It takes what their needs and what their wants are first and foremost. So whatever impact that has, it may not be in the academy, and hopefully the academy will recognize it. The impact really for me that is meaningful, does it matter to the communities that I work with? Is the work that I do understood? Does it make a difference, right, in their daily lives? And so this is where I am in my career, and sometimes that's not possible when, you know, you're at different phases of your career.
Yeah, and that presents this huge disconnect between, you know, if it isn't scholarship, but it is directly addressing the needs and the wants of a community, then should we then be changing what we view as scholarship to ensure that it's including those individuals, that community voice is there, and that we're indeed addressing those needs. So there's that call for that shift in what is being done. And so do you want to talk a little bit about some of the effective tools that you have used, and you may have talked about this, you did talk about this a little bit, in shifting towards that curriculum that focuses on anti-racism and anti-oppression. And so specifically, more ideas on like pedagogy and classroom engagement.
Sure, I've written about this too. So there are other ways that people can engage with it if they can't get all of it. I think for me, I'll try to break it down into sort of three major sort of components for me. One is how am I presenting information, right, in the classroom on a specific topic, right? So how will information be presented? And what this requires is often, like I said, you have to offer, at least if you want to do this, right, you might want to think about offering multiple modes of engagement, right, outside of written text, right? You have to sort of really think about giving students sort of options. And this is entirely based on student driven, right? Meaning that students are incredibly capable of driving their own learning, right? And so you have to also really think about how you sort of decenter your own power and privilege by giving students options, and really thinking about material cost of courses, right, as well. Can you make this kind of information free and accessible to students? You absolutely need to really rethink in the sense of how will information be presented, whose perspectives are represented or not, right? This is really an important part of this aspect. The second way is developing supportive course policies. So building flexibility into course policies, recognizing a shared humanity, right? Meaning that we all have things, and this past year should have taught us all, right? That we all have things that we are handling. And so this notion of rolling deadlines, right, for me has been incredibly liberating. I know it confuses some students and some students need more guidelines, but for me, it's about allowing students not to have to sort of produce a death certificate. Like, I mean, you know, things that really are just not necessary. So this notion, I'm not grading, right? I have to come to terms with the fact that I'm not grading on when you hand something in. I'm grading it on what you actually hand in. So I've kind of let that go. These really strict guidelines around deadlines. You know, recognizing screens as accessibility and learning aids, thinking about protecting student privacy, teaching students or revealing hidden curriculums, right, within courses in terms of communication norms, campus norms, also sharing resources that are beyond academic support. So thinking about offering information, providing support for health, for safety, for food and basic needs, right? All of these things are really, should be sort of part of thinking about how your course policies themselves become more supportive for students in your classes. And then the third thing is designing inclusive assessments. So options beyond oral participation, right? Because oral participation, again, privileges a particular form, right, of an assessment. Really thinking beyond exams and research papers, right? A wide variety of ways. So I often teach how for students to write op-eds or film reviews, rapid response sort of papers, different things that really become useful for them to engage with a broader sort of public, I guess. Alternative grading practices, this is a little bit more difficult, you know, and this is something that I'm still working on. And also giving students choices and picking the assignments that they want to do, that they feel really sort of driven to do, right? Instead of having this sort of cookie cutter way of, you know, a very top-down way of thinking about how students should be assessed. So those three things: how will information be presented, developing supportive course policies, and designing inclusive assessments. I think those are the three major ways that I've thought about sort of shifting the curriculum.
I think those are some great examples, really tangible ways that individuals can, you know, try to create these classrooms that are indeed accessible, that focus on anti-racism, anti-oppression, and then decolonializing the process. So I want to thank you for sharing your time with us today and sharing all these great nuggets on like how we begin to think about decolonialization, and then how equity, inclusion, diversity work can come together. And so I wanted to provide you the opportunity if there were any final thoughts that you wanted to share with the audience, but thank you again for participating in this interview. More of an interview, I think, than a dialogue, but you shared so much great information.
No, and I think all I want to say is that this is never a set process, right? This is not a finished product by any stretch of the imagination, right? One of the things that I have come to terms with is that I was never taught to teach, ever. I became a teacher because so many teachers were really important people in my life, right? And oftentimes we're sort of becoming default teachers, right? Because we are in the academy. So it's also to recognize that maybe sometimes, what and how you teach, right, really comes from watching others and how you yourself learned. I loved school, I love learning, but it became almost really sort of, I was at odds with myself when I stepped into a classroom. There was something deeply uncomfortable, not about sharing information, right? But just the way that I was engaging with students. And so it's taken me years to really sort of rethink what this looks like, and to also sort of, understand that I also need to be happy in the classroom, right? What is enjoyable for me? What is it like to learn with students, right? I am learning just as they're learning. And so really sort of decentering my power in the classroom, that's really hard, because I didn't know what that looked like. And so these are things that I think are really important practices. And I think it helps us, right, rethink other sort of positionalities and also our relationship to the field more broadly, such as, in the allied health field or in global health as well, right? It helps us think about sort of decentering power and privilege, right? And so, what that classroom is sort of more of a microcosm of broader sort of things, I think.
Well, thank you so much for providing those tips. We are seeing that there's some folks who've shared in the chat, I guess, that these sort of rolling deadlines that you mentioned would have been helpful, perhaps for their child. Mm-hmm. I'm sure that there are many of us who teach who think about how rolling deadlines might have been helpful for the work that we do and the workload that we are all trying to balance. So thank you again for leaving us with those final 3 suggestions.
Thank you so much, Courtney, for your time. I really enjoyed it, and hopefully there will be more spaces to have conversations.
Great, thank you, Courtney and Thurka. That was an amazing conversation. That it really kind of touched on so many different aspects of this work, and that I'm still kind of grappling with all the ideas, and also comes to show you how different perspectives, different theories, different lenses can bring different definitions into the debate and into the conversation, and then how do we grapple with these differences and move forward? So. I think on the next days, we're going to try to refine more and more where we're going, and hopefully reach a point where we can, at least, as you say, Thurka, this is a work in progress. It hasn't been solved, but we need to be iterative. We need to be innovative. We need to continue to work towards our common goals. So I really appreciate that. I'm kind of taking some notes from your conversation. We started with Ijeoma, we started with Dr. Jarrell, Dr. Gallo, Dr. Nnodim Opara. We went to the students, we came back to kind of the panel of experts, and now we close with here. I've heard a lot around humility, right? Being humble, being reflective, right? Being self-critical, right? This is kind of things that I've heard a lot. I have heard a lot around the intention and the intentionality of our actions, and how do we create and style change for long term. And I also heard a lot about, this is a conversation that needs to happen in kind of a systems structure, right? It's not a superficial conversation. It really needs to be a deep understanding of what's happening in the arrangements of our structures that are allowing these things to perpetuate themselves, and then how do we look at those things and change. This is an ongoing conversation. I'm really excited to start day 2. As a reminder to all attendees, tomorrow we start again at 9 a.m. We have welcome words by Dr. Roger Ward, and then we move into our other keynote panel, which is Dr. Agnes Binagwahu and Dr. Samba Sow. And then we have a conversation with students from other career points. So again, I'm going to close this activity today. I really appreciate everyone's attention, all the panelists that have attended, the students, the trainees, and my colleagues and behind the scenes that have done an amazing work. So have a great afternoon, a great evening, or a great morning, depending on where you are. And we hope to see you again tomorrow. Have a great day.